Very good evening, and thanks to everyone for joining us today. I, Ankit Dogra, along with my teammates, Dr. Deepika Chhabra and Mr. Amit Saxena from Medical Services Jagsonpal Pharmaceuticals Ltd, welcome you all to another webinar from the Pearls of Wisdom Key Opinion Leaders to share knowledge on a very pertinent topic, metabolic syndrome in South Asian countries, organized by the South Asian Federation of Menopause Societies, SAFOMS. The academic partner for today's program is Jagsonpal Pharmaceuticals Ltd, makers of LycoRed soft gels, the ultimate cell protector containing world-process patented complex LycoMeto, all natural extract containing lycopene, zinc, and selenium. When metabolic syndrome affects quality of life, LycoRed reduces oxidative stress and offers protection at cellular level. Our other excellent products include Doxypal DRL capsules of 100 mg doxycycline with lactobacillus for broad spectrum antibiotic and immunity boosting effects, and Cystelia-M tablets formulated with the ideal 40:1 ratio of myoinositol and D-chiroinositol with methylfolate and vitamin D3, the right combination to restore reproductive health in women. We thank Dr. Manendra Ahuja, Vice President, SAFOM, for taking Jagsonpal Pharmaceuticals Ltd as the academic partner for today's program. We extend a warm and hearty welcome to all the esteemed experts and attendees. Dear attendees, we request you to post your thoughts, opinions by text in the Q&A box. Please note this webinar is streaming live on Facebook and the link has been shared in chat box. To refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. Now, we welcome Dr. Manendra Ahuja, the visionary with whom we have been working since she was the president Indian Menopause Society. She was the first one to write a book on step-by-step management of menopause in 2010. First chapter in LycoRed on menopause. Her crusade for digitalization of electoral processes, digitalization of education, exams and journals, and the period of COVID-19 made it possible. And thus, her Society of Meaningful Life Management was registered with the same aim. Now, as Vice President of SAFOMS, she is spearheading this project of cross-sectional study on relation of menopause to metabolic syndrome in South Asia. We at Jagsonpal wish her best and would collaborate wherever possible. Ma'am, requesting you to kindly take the proceedings of the program further.
Thank you, Jagsonpal, for the kind words and for being there whenever I needed you there. I think it's a dream come true for me today, because metabolic syndrome in South Asian women has been my passion for many years to come. And it's really heartening for me and to welcome all of you to this webinar of SAFOMS on metabolic syndrome in the South Asian countries. The purpose of this webinar is to introduce our concept of research, to introduce our partners and collaborators, to find out how we go for our future data collections and inquiries, our future expected outcomes and our dreams, and to introduce a luminary of faculties who will be introducing you in reality to the topic of metabolic syndrome in South Asian countries. So my thanks and my gratitude to SAFOMS President Dr. Rohana Haththotuwa, who has not been able to present here physically because of his traveling from UK to Sri Lanka today only. My thanks to past president of SAFOMS, immediate past president of SAFOMS, Dr. Jaideep Malhotra, for being here today and always for me there like a sister only. And my thanks to all the country representatives and IM and Menopause Society presidents from each country. Dr. Rubina Sohail, Dr. Rubina Hussain, Dr. Sumbil Sohail, Dr. Batul from Pakistan, Bangladesh, Dr. Brigadier Suraya Hussain, who is also happens to be the Vice President of SAFOMS, and Dr. Sheikh Zinnat Nasreen and all the collaborators from Bangladesh, Sri Lanka, our President, past President, Menopause Society, Dr. MDP Gunaratne, present President, Menopause Society, Dr. Sanat Akimya Mana, Dr. Piyusha, who is the Secretary General, and from India, Dr. Shobna Mohandas, who is our President of Indian Menopause Society, Dr. Neelam, who was the past President and a coordinator, Dr. Sudha Sharma, Dr. Choranur Ambuja, who was the immediate past President and country representative to SAFOMS from India, and from Nepal, Dr. Dicky Bista, because she gave me the permission to call her Dr. Dicky, and she's a lovely person. He's the president of the Nepal Menopause Society, and immediate past president of Nepal Menopause Society, Dr. Sushila Sreshta also. And then it's my privilege and honor to welcome all our esteemed, glittering faculty, Dr. Rakesh Sahai, who is going to talk on adipose tissue as an endocrine organ, Dr. Ashraf, who is going to talk on the diagnostic challenges, which is very, very important topic. Dr. Sunila Khandelwal will go to the root of the problem, the relationship of menopause to metabolic syndrome, and Dr. Sandeep Kharab on the relationship of PCOS to metabolic syndrome. Dr. MDP Gunaratne from Sri Lanka, who has been talking very, very passionately about metabolic syndrome in South Asian countries, and our collaborators, which will be presented later on at the time of panel, all our chairpersons, Jagsonpal Pharma as our technical collaborators. And I must introduce my young upcoming Dr. Priyanka Sharma, who has already taken the internal ethics approval in the ESIS Medical College, Faridabad, and she has already started data collection. So my clapping and 3 cheers for that young pioneers of ours. And they have done lots of research as principal investigators during COVID-19 also. And she's associate professor in the ESIS Medical College. So with these words, I'll introduce Dr. Rohana for his presidential address. Dr. Rohana Haththotuwa is our president of SAFOMS and founder chairman of the Nine Wells Care Mother and Baby Hospital. And he is the Secretary General of AOFOG and President South Asian Federation of Obstetrics and Gynecology. So his commitment to the women's health at the international level is unparalleled. He's the President World Justice Organization, past chair, Menstrual Disorders Committee of FIGO, and past president of Sri Lanka College of Obstetrics and Gynecology, and past president Sri Lanka Menopause Society. Dr. Rohana, we are missing you here because you are exactly looking like our hero only, and we are ready to hear from your words of wisdom. Welcome, Dr. Rohana, on virtual platform in a virtual message only.
Good evening, everybody. I am Rohana Haththotuwa, the president of SAFOMS. I'm sorry that I am unable to join you virtually on the virtual platform because I am traveling at the time of this session. So please excuse my absence virtually. So firstly, I wish to welcome all of you to this webinar on metabolic syndrome in South Asian region and for the pearls of wisdom. So I'm very thankful to Dr. Maninda Ahuja, who is the Vice President of SAFOMS, and her team was spearheading and organizing this wonderful program for us today. I mean, Dr. Maninda Ahuja has been very, very active and in organizing, and she has been pushing all of us for this webinar, which is a very timely webinar where we will be discussing the metabolic syndrome in this region. Just for those who may not be aware what SAFOMS is, SAFOMS is South Asian Federation of Menopause Societies, which consists of the menopause societies of Bangladesh, India, Nepal, Pakistan, and Sri Lanka. So this is the federation of all these menopause societies of this menopause societies of South Asian region. So today we will be discussing this important subject of non-communicable diseases. As we are all aware, non-communicable diseases is a major challenge to all of us in the South Asian region. This is non-communicable diseases has become the major contributor to deaths in this region, and it is the rise seen in the South Asian region is more than what is seen globally. And so principally the non-communicable diseases which are principally involved are the cardiovascular diseases, cancer, diabetes, and chronic respiratory diseases. So it is very unfortunate that we have not been concentrating very much on these diseases by our federation earlier. So, but I'm thankful now that Dr. Maninda Hoja has taken a very active role in taking this forward, and she is having not only this, many other research programs also so that we will be addressing these non-communicable diseases in the South Asian region in much more, so that we all in the region will be beneficial. Today, I am very happy to note that very senior members of SAFOMS, including Dr. MDP Gunratna, the past president, and Dr. Jaideep Malhotra, the immediate past president, Professor Rubina Sohel, Dr. Piyusha, and so many others from the SAFOMS, and also many leaders in this non-communicable diseases from the South Asian region are participating in the discussions and the deliberations today. So I'm sure we all will be able to gain much information and from this webinar which will be held today. So I wouldn't like to take any much more time of yours because there is so much for us to learn from these lectures and discussions today. So I would hand over to the moderator to continue with the program, and I wish the program all the success. Thank you very much.
Thank you, Dr. Rohana, for those wonderful words about SAFOMS introduction and the introduction of the topic also. Now we will be having a few words from Dr. Jaideep Malhotra, who was the immediate past president of SAFOMS and a founder member also. And she's one of those active ladies who has not only taken her center forward, but the country and the international bodies also. She has pushed forward with her presence and with her participation. And you name a institution and she is there, whether it was ISAR, ISPAT, FOGSI, or Menopause Society. She has been president everywhere, and she has spearheaded so many of journals. So if I am going to talk about her, then our time will be 2 hours, will be finished in this only. So the only thing is she is a recipient of honorary FRCOG, so many awards, and at the social level also, they are doing lots of community work, which is really admirable. So from academic to community level to her personal life. She's an excellent example of an emancipated and moving forward woman. And Dr. Jaideep Malhotra, it's an honor to have you here among us. And there are lots of projects which she has started, but let's hear from her, because she was the first one to tell me when I sent a mail to SAFOMS that I want to do this project. She was the first one. I'm ready to be your coordinator. Thank you, Jaideep, for encouraging, and we are ready for a few words from you.
Thank you, Maninder. Thank you so much, and a very good evening to all of you. First of all, my heartiest congratulations to each and every one, and to you, Maninder, personally for taking the lead as always. And I think it's a phenomenal job which we are actually looking forward to. And I'm sure together we can, because this is something which we have to understand. And in fact, it's been a long time that we have been talking about that the NCDs are on the rise, and women and metabolic syndrome are a major contributor to it. What is also important is that all these NCDs are coming at a much lower age in our region than the Western world. And we don't have any data or research projects which would actually tell us or give us the true picture. And I think these efforts are today going to, set the foundation for a very long-term strategic changes which might be put in place for us to have a good quality of life, and also, to reduce the disease burden in the future generations. I congratulate each and every one of you, and I would say a dedicated commitment from everyone is very important for the success of any program. And when I see all these beautiful friends from all over the region, it enhances. Today I was feeling very low, but looking at everyone's presence here has really made me very energetic. And this is the positive effect of a whole team working together. And heartiest congratulations and all the best to our team leader, dear Maninder. Keep on, pulling everyone together to do the job which is really required by our country and our region. God bless you all, and looking forward to all the deliberations.
Dr. Jaideep Malhotra, for those wonderful words, and as always hitting on the mark and to the point. And now I'll hand over the proceedings to Dr. Priyanka Sharma. Please show a slide of Dr. Priyanka Sharma. She is the Associate Professor, Department of Obstetrics and Gynecology, ESIC Medical College and Hospital, Faridabad, MD Gold Medalist, 12 years of experience in the OB-GYN, member FOBC MTP Committee, and executive member of Faridabad Obstetrics and Gynae Society. Very keen interest in academics. I must say that very keen interest in academics, in maternal fetal medicine, quality in healthcare. And she has authored original research and review articles in several national and international journals. And she was the co-principal investigator in COVID vaccine trials also. And she is the first one who took one of my collaborators, first ethics clearance from her hospital, and she has already started the data collection. Welcome Priyanka Sharma as my new champion and new torchbearer to SAFOMS countries and to the health of the women of this country. Now I'll hand over to you for further proceedings. Thank you, Priyanka, for being here.
Thank you so much, ma'am, for that wonderful introduction. A very good evening to everyone. So we have today with us a constellation of stalwarts in the Department of Obs and Gynae from the entire Southeast Asian region. It is indeed a privilege and a pleasure to host this evening, because it's going to be a privilege to listen to veterans in this field deliberate about a very pertinent yet a very ignored topic and a very ignored population. Knowledge needs to be cultivated before it can be harvested. And it is really remarkable of Dr. Maninder Ahuja, ma'am, for having thought of this initiative, for having taken the initiative to generate informed opinions in midlife health, a topic which she is very passionate about, and I'm really grateful to her for this opportunity. Without wasting any further time, I would like to introduce the first topic, that is the way forward for women's health in South Asia, research on relation of menopause to metabolic syndrome. I would like to introduce the chairpersons for this session. The first chairperson is Dr. Neelam Agarwal. Madam is professor in the Department of Obs and Gynae, PGI Chandigarh. She is founder of president of the Stillbirth Society of India, past president of the Indian Menopause Society, past associate editor of the BMC Women's Health Journal, senior member of the editorial board of BMC, chief editor of the Journal of Midlife Health, has been the nodal officer of the Stillbirth Review Committee and the member of working groups of ISA. She is interested in high-risk pregnancy and perinatal health as well as menopause. We welcome you, ma'am. The second chairperson for today is Professor Ambuja Choranur. She is president of the Indian Menopause Society, the research committee chairperson for SAFOMS from 2021 to 2023. She is retired professor and head of department of Obs and Gynae from Osmania Medical College, Hyderabad, visiting professor at Savita University, Chennai, All India Vice President of the Family Planning Association of India, faculty and resource person of the NBE, treasurer of the Society of Obstetric Medicine India, and has been a peer reviewer for illustrious journals like the Journal of Obs and Gynae of India, JMH, and MRIMS Journals of Health Sciences. He is consultant editor at JK Science, Journal of Medical Education and Research, and has been a UG and PG examiner for various medical universities. We welcome you, ma'am, and we look forward to this introductory session.
Priyanka Baskaru. Thank you, Priyanka, for your kind introduction. Introduction is ज़्यादा हो गया instead of talking, and I am overwhelmed with joy to participate in this program, which Maninder has started. And hats off to you, Maninder, for organizing such a beautiful workshop. And to introduce about Maninder, everybody knows about her. So I'm not going to tell much, because if I start talking about her, it takes more than half an hour. So instead of that, I'll tell four very important things which all of us are very proud of her. One is she's founder president of Society of Meaningful Life of Management. It's going on very well. And she is vice president of SAFOMS. And as a member of the SAFOMS, she is there in the SAFOMS for more than 10 years, from the time of it started with Dr. Anklesaria. That time onwards, she is an active member and the executive member. Am I audible?
Yes, madam.
Yes. There are so many books she authored, and another thing is she was editor-in-chief of Journal of Midlife Health. This is an index journal, and very few index journals we have. In that one, to be an editor-in-chief is a great thing for her. And she has got so many research original papers and so many awards she has got. So this is Maninder, who is going to tell about the way forward for women's health in South Asia. Maninder, it's nice to have you here. Please carry on with your message.
Thank you, Dr. Ambuja, for the kind introduction. And now let's move ahead what we are today here for our dream project, all of us from the South Asian countries, and for the women of South Asian countries also, on the metabolic syndrome in South Asian women. What is science and research? Not all of us become professional scientists, but most of us are thinking persons, and we can do some sort of research at any level, whether it's in our personal lives, in our domestic life, or at the scientific levels. But just making a few observations only, we can do it. Some people say if we knew what it was, what we were doing, it would not be called a research, would it? No. But for research also, you need to formalize curiosity. You have to be poking. You have to be prying with a purpose. So that is called the hypothesis. You have to go ahead with the hypothesis. And then you have to work very hard to prove that hypothesis. You may not always be right, but at least you tried. So all of us have to make that effort to try itself. So why? Why did I try? Why was I passionate about the metabolic syndrome in South Asian women? Because I saw my colleagues who were having a premature death because of myocardial infarctions, because of asymptomatic myocardial infections, because when they were taking HRT and they didn't have any biochemical parameter or anything, risk factors, apparent risk factors, and they had the myocardial infection. And when I had the myocardial infarction, I didn't have the infarction actually, I just have the coronary artery disease. And I went there, I am having some atypical symptoms. The cardiologist won't listen to me. They say, you're absolutely healthy. All the parameters are normal. But where were we missing out then? We were missing at something, because I had TI also. And at that also, they did everything from carotid artery, angiography and everything. The only thing which they did not do at that time was the CT angio, which was done when I went there and told them that I had some atypical symptoms. So my deliberations today will be with all these specialists, where we should start the doubting, where we should start the new investigation, where we should be moving ahead. Perhaps we are already coming to the genetics, because this is one of the emails where I got, where they are telling us to go for the genetic studies now to predict the coronary artery disease. So all of us know about the metabolic syndrome, that it's a cluster of interconnected factors that increase the risk of CAD and diabetes mellitus, and it includes the dysglycemia, dyslipidemia, central obesity, and hypertension. And they are more common metabolic syndrome, CVD, as individual risk factors in the post-menopausal phase, so much so that from a pre-menopausal age of 13.8% incidence, post-menopausal it goes as high as 60%. And the main thing is that it increases with age, increasing glucose intolerance. And in the post-menopausal women, it can be because of the hypoestrogenic state and redistribution of the fat also. The menopausal symptoms have not been studied to that an extent in our countries, and menopausal metabolic syndrome and menopausal state in South Asian countries had not been studied at all well. So that is why we need these sorts of studies in a South Asian population also, because we are a different heterogeneous group. We have earlier age of menopause, where our diet is different. Our transition from perimenopause to menopause is different. So we have to study all those factors, where the risk factors are coming up, whether they are coming from the family history or from the transition, hypoestrogenic state or whatever. Or maybe, are they because of the our midriff obesity? So that is the Dr. Rakesh Sai will be talking on. Various studies have reported association, aggravation of symptoms, menopause association with obesity. So we will be looking into that. Might be our diet, Dr. MDV Gunaratne will be talking, or genetic factors might be there. So Dr. Sunila Khandelwal on the whole will be talking. So what about the other factors which are there? Sorry, it's not. Yes. So that is why this topic is important, because of the magnitude of the problem, because of the public health expenditure, because the prevention is possible. If we know the risk factors, we can do the prevention, we can start the MHT, and quality of life and quantity of life, both can be challenged easily for a better outcomes. So that is why we need this study for the South Asian women. So we will be highlighting special consideration as risk factors for the metabolic syndrome in the women of South Asia, so that the preventive efforts and menopause hormone therapy can be instituted safely. So it's a multinational, multicentric study, cross-sectional study, I being the chief investigator, but we'll be having collaborators from each and every country. And already some of us like Sunila Khandelwal have joined here. So objectives are to find out the incidence of metabolic syndrome in the pre and post-menopausal women. What are the criteria which should be used for the this challenging condition diagnosis? Dr. Ashraf will be talking. Then secondary objective will be their relationship between age of menopause, metabolic syndrome, profile menopausal group by IDF parameters, relationship between family history, hypertension, diabetes, CVD, metabolic syndrome, menopausal women, association of metabolic syndrome with diet and lifestyle, relationship with previous history of PCOS or PID, relationship between anthropometric parameters and metabolic syndrome, relationship between biochemical markers and metabolic syndrome, and when and how to start the preventive measures. What we have to look into. So it will be a cross-sectional study, and there are two ways of collecting data. I'm going to tell you in brief about how we are going to conduct this study. One will be through the Google Forms, and one will be in the clinic settings of the healthcare provider. Google Forms will be filled by the healthcare providers or with the trained medical staff only. And as we have talked about, participants will be asked to fill in details about their personal history, family history, risk of metabolic syndrome, and everything that I'll be highlighting in the few coming slides again. Inclusion exclusion criteria is very simple, just should be above 35 years of age and below 60 years of age. And study period, normally we are taking 3 months, but I don't know, because some of the countries might have problem in getting the ethics approval, and some of the countries are facing some internal problem like Sri Lanka. So we might be delayed a little bit because of that. So the methodology, basically, like the data collection by the persons or by the trained paramedical or the healthcare providers on the Google Forms or in the hard copies. Statistical analysis which has been done, I'll be telling you, we have taken the ethics approval already. This ethics approval is there. Then we will be discussing that data again among our experts on the virtual meetings, and final draft will be consensus and publishing will be there. Now, statistical analysis, already we have done how much sample is required. So by Mediva Group and AIMS biostatistician, Dr. Perumal Vanamil, he is helping us. So what the data we need from as pre-menopausal women and as the post-menopausal women, they have calculated. I'm not taking your time to go into details of those calculations. I have sent, and again, I'll be sending to all the countries, all this concept note and methodology again. And the Nepal, Sri Lanka, and Bangladesh, they are required to fill up 300 patients data. India and Pakistan being a bigger country, we need about 1200 premenopausal and postmenopausal. Nepal, Sri Lanka, and Bangladesh require 270 cases, so total about 600, and we need about 1100. So total we need about 2300 cases. We should aim for 2500 cases because some of them will be discarded later on because of not being properly filled forms or anything. So what we will be collecting data is on the IDF criteria only we have taken. There's the central abdominal obesity will be taken. If the circumference is more than 80 centimeters, hypertriglyceridemia, triglyceride more than 150, or under treatment of dyslipidemia, HDL less than 150, high blood pressure more than 130 to 85. All these are IDF criteria which they have said we should be taking for the research purposes, and fasting glucose level of 100, more than 100 milligram per DL. IDF criteria of central obesity with any two above factors will be taken as the statistical analysis when we carry out. So we will be collecting the blood sample of the in the morning fasting samples, or the participant, they will be required to have their data of the previous 3 months will also go, or they should get it done and then they can fill up the form. So all these age, country, address, ethnicity will be there. Then family history, history of PCOS, LMP, that I'm again going to tell you because exactly I'll be showing you how the forms will be filled. So height, weight, abdominal circumference, we are giving you instructions how they should be taken. The height should be taken by standard because most of the private practitioners know it. But even if they don't know it, we have given them in the writing when they are collecting the data, how the height will be taken, how the weight should be taken, how the waist circumference should be taken up just above the iliac crest or in between your ribs and the iliac crest, superior margin of iliac crest. And blood pressure, 2 readings will be taken. Patient information sheet is there. That is there in the Google Forms also, and that is there in the hard copies also. We have to inform the patients and we have to take their consent that we have informed them about the studies. They can take anytime they can opt out of the study, and they know the advantages of being a part of the study, and they are giving consent for being part of that study and sharing the blood sample. And second signature which we are taking is if there is a follow-up study, they agree to participate in that follow-up study also. So these are the patient information sheet, and which all of you either have to sign in the, that is taken as granted in the Google form, or in the hard copies you have to take them sign. Then comes the personal information data is there, which will be kept secret, which won't be shared. But if we have to do the follow-up studies, we might need them, for which we are taking their consent. So age, mobile number, address of the country, country of residence, age in years, wherever they are, ethnicity, Asian or others. These are the columns which have to be filled. And then personal history, age of menarche, last menstrual period, are you a healthcare worker, doctor or paramedical, and family history in the first degree family members. That is what we have included in the parents, mother, father, brother, sister, grandparents, maternal and paternal grandparents, history of diabetes, fragility fractures, hypertension, CHD, because all these are related to metabolic health syndrome. Then if there is any history of PCOS, history of hypertensive disorders of pregnancy, number of pregnancies, diet, and exercise, one column is there, where number of you are doing a sedentary job or a desk job, or your working job profile involves moving around, 15 minutes of exercise or half an hour of exercise or regular gym exercises. That is what information we are collecting. Then from the menopause transition, because that is the very, very important phase where we have the development of the risk factors in menopause transition. And for that, we are going to ask them if they have any changes in their bleeding pattern, if they are not menopausal. If they are menopausal, then they don't have to answer. Then if you have hot flushes in the post-menopause or pre-menopause, or whether you had taken menopause hormone therapy, and are you still on menopause hormone therapy? And then we come to the physical examination, which I have already talked to you, in the weight in kgs, height in centimeters, and waist circumference in centimeters, and blood pressure systolic over diastolic. Then biochemical tests, which we have already highlighted, fasting blood sugar or hemoglobin A1C, total cholesterol, HDL, biochemical LDL, and triglycerides. These are all we required. This is a very simple questionnaire which anybody can fill up. Even the doctors from their busy clinics can do it. So with my, again, request all of you to become our hands together for this, taking this one step forward, because we just don't have to see the whole staircase. Just take that one step forward. We will be moving ahead by our persistence, ability to keep move forward in spite of difficulties. And research is formalized curiosity. If we all of us are curious and we want to move ahead, we will be doing it together, because this is just the beginning. After that, we'll be having more webinars everywhere to create this health awareness, because this is very much required. And you will be astonished when I ask some of the lady doctors, what are your triglycerides and blood sugar? Why should we get it done? We are healthy. Even I was a healthy looking person, but then I had lots of problems. That's why I want to initiate all of you into this, at least look into your parameters. That's why I started in the healthcare workers, healthcare professionals only. And this is just the beginning. And many teaching institutions, they have already taken up projects, which I will be telling you: AIMS, Maulana Azad, ESI Hospital, PGI Chandigarh, Medical College Sonipat, Medical College Amritsar. So I'm so heartened that all these hospitals are later on going to take research project on for their PG students on metabolic syndrome only, because there are many aspects of metabolic syndrome. We will be together talking just 3 or 4 topics. And from genetics to inflammatory reasons and everything, there are lots of work which has to be done. So coming together is beginning, and keeping together is progress, and working together is success. And I'm sure all of us will be working together to make it a success through exercise, diet, medication, whatever is required. But we are together in this. And this is the only introduction I have to give you. If you need any help, I'm there, available at all hours, 24 hours. Anytime you can pick up a phone and call to me or write to me. Thank you very much for being here. And Dr. Priyanka, you forward, or Dr. Neelam Agarwal, do you have to give any comments? Thank you.
Yeah, thank you, Maninder, for your wonderful presentation. And believe me, as Maninder has shown it to be simple, it is really simple. It will take just not more than 10 minutes. In the first visit, we can record all the history, everything, just give some counseling to the patient, talk to her, tell her to just in routine get her lipidogram done and fasting blood sugar. That's all. Nothing else is needed. And next time she comes back to you, you can, at that time, you can measure her waist circumference and her BMI and take the investigations. So that is the only full protocol. So I don't think it is difficult. At PGI-MER, I already had a thesis done, exactly similar thesis, and it was not difficult at all. And also for this project, I have got the provisional clearance, just 1 or 2 small little clarifications. And after that, PGI's ethical clearance will be there. If any institute needs our help to show our ethical clearance for in their institutes, so as to get it fast clearance, because the bigger institute has given it, I will share with you. Thank you, Maninder. And it's really a very nice. Yeah.
Thank you, Dr. Neelam Agarwal. That is the main thing which you have said, that it's easy, it's feasible, it's practical, it can be done. And still, I will tell you, the lady doctors, I mean, healthcare professionals of various specialities are still not willing to fill up their forms, because we are not bothered about our own health. That is the issue. That is where the sensitization has to come forward. Dr. Priyanka, to you. Any comments? Priyanka, please take it.
Thank you, Dr. Maninder ma'am, for this very excellent talk. And thank you, Dr. Neelam Agarwal, for this wonderful initiative, and Dr. Chorana Rambuja. The next topic is diagnostic challenges in metabolic syndrome, and I would like to introduce the chairpersons for the next session. The first chairperson is Dr. Piyusha Milani Atapattu. She is professor in physiology and specialist physician, Faculty of Medicine, University of Colombo, Sri Lanka. President of the Physiological Society of Sri Lanka, President-elect of Menopause Society of Sri Lanka, and the Deputy Secretary General of the SAFOMS. She is Vice President of the South Asian Association of Physiologists. We welcome you, ma'am. The next chairperson for the session is Dr. S.K. Zinatara Nasreen. She is Professor and Head of the ZH Sikder Women's Medical College and Hospital, Chairperson of the Scientific Committee of the OGSP, Secretary General of the BMS. She's Secretary General RCOG Representative of the Committee, Representative Committee of Bangladesh, Secretary General of the Polycystic Club of Bangladesh, Secretary General of Osteoporosis Task Force, Organizing Secretary of the BPS, Editor-in-Chief of the Journal of ZH Sikder Medical College and Hospital. She's a member of the IMS, and she has had multiple academic achievements, and she has been a prolific author on menopause and has had many national and international publications. I request you to kindly introduce the speaker for the session, Dr. Muhammad Ashraf Ghani.
Thank you very much, and it's my heartiest thanks and gratitude to Dr. Maninder and all the dignitaries here for this wonderful webinar, and I'm really looking forward. Now we're going to listen a very important topic, that is the diagnostic challenge of metabolic syndrome. And our honorable speaker is Dr. Muhammad Ashraf Ghani. He's a professor of endocrinology, Sher Kashmir Institute, Medical Science. JK India, head of the department, clinical research, and sub-dean research of SKIMS. He's the founder president of MP PCOS Society. Dr. Mohammed is also the member steering committee. He's the PGR member. He's the PRG member. He's the expert member of SEC Endocrinology. He's the expert for faculty selection committee, and he's a member of editorial advisory board. He's the editor of Diabetic Obesity National Journal, AEPCOS newsletter, and he's the guest editor of Frontiers of Diabetes. Dr. Mohammad Ashraf Ghani is also a member of a steering committee for the adolescent PCOS, that is APPES. He's the reviewer, member of the Biosafety Committee of Department of the Biotechnology, and he's the executive member of Indian Thyroid Society, and he's a member of INOSA Guidelines, that is ICMR, and he's the member of Consensus Guideline Endocrine Society of India. He's actually stalwart. So may I welcome Dr. Mohammad Ashraf Ghani for your presentation, please.
Thank you very much for your kind introduction, Dr. Zenith. So at the outset, let me express my deep sense of gratitude to the society SAFOMS, especially Dr. Maninder, who gave us an opportunity to interact with your society. So I am representing my society, Metabolic Syndrome, Pre-Diabetes PCOS Society, where I am the president. And I am also finding our secretary, Dr. Rakesh, there. So I congratulate Dr. Maninder for taking this initiative as a study, which is a sort of a real world scenario across the South Asian countries. So we are doing something of the similar sort currently, and we have actually taken the same Mediva, who is supporting us taking the real world scenario of polycystic ovary syndrome in India. However, it would be my keen interest to take it across the South Asian countries as well. So we would like to take the lead from you. You will be our guiding light there, and you can connect us, or we can even collaborate with each other to take this initiative there. I must express the gratitude to all your colleagues that some of them have helped us. We are taking a national task force on polycystic ovary syndrome, which is being supported by Indian Council of Medical Research. And fortunately, I am the chief coordinator of that study. We have completed the phase 1. Results will be out in another 6 months. And that is just prevalence and seeing the comorbidities in PCOS. And in phase 2, we are going to have another 31 centers in the country, which will be supported by Government of India. It is a flagship project for ICMR. And this task force will probably give us significant information about the women health in India. And I would be very keen to take that also across these neighboring countries and see how this polycystic ovary syndrome, it is comorbidities, it is life trajectory different from the Western data. So with that, my task is today to talk about what are the challenges in the metabolic syndrome. So we have this society. I have actually named our society as Metabolic Syndrome, Pre-Diabetes and PCOS. Why we have named this society, a lot of brainstorming happened when we were trying to name the society, was just to make people aware that diabetes is not different from pre-diabetes, pre-diabetes is not different from metabolic syndrome, and that is not in turn different from PCOS. This is actually gamut of non-communicable diseases, which just tell us that you have polycystic ovary syndrome and other metabolic conditions. They are almost having a similar pathophysiology, similar presentation, and even similar the consequences. So because understanding these diseases have something to do with lifestyle, or we can say modern lifestyle. So if we understand their origin, their trajectory, and then treatment, so we may be able to actually contribute towards the prevention of these disorders, which is most likely the most important modality in the developing countries, because we cannot afford to treat and these complications of this condition. As I have said, that I will be talking about challenges in metabolic syndrome. So for the limitation of the time, there is lot much to be said about metabolic syndrome, since Gerald Revan made this revelation that there are several metabolic constellations which he named as syndrome X or insulin resistance syndrome. There are several names which have been given to this constellation of metabolic conditions. So the challenges are, first of all, definition of metabolic syndrome. If we go that there have been several commentaries, several editorials, several publications since Gerald Revan from 1883 till this time, that metabolic syndrome has evolved in a way that every time you try to revise some different metabolic complications or metabolic associations are defined in this. There are only 3 definitions which are valid till this time, but actually if we see, it is a cluster of interconnected metabolic factors which are actually increase your risk to coronary artery disease. But now if we see today, it is not just the coronary artery disease risk. Initially it was said that it only increases coronary artery disease risk. But if we see today, it increases chronic inflammatory conditions, it increases pro-thrombotic states, it increases sleep apnea, it increases non-alcoholic fatty liver disease, it increases the chances of having mitosis. Increase means cancers. So if we see that every time a new definition or a new metabolic constant is defined, the metabolic syndrome may be redefined. But there are several metabolic syndromes. The most important and most accepted one is National Cholesterol Eradication Program, ATP3 guidelines. You don't need to be told, because I think most of us are well aware of this condition, where the definitions since 2001, the definitions have come, and in between the additions of American Diabetes Association changed the glucose cutoffs. Because of the hyperglycemia and because of the blood pressure levels by GNC have been changed. So accordingly, the definitions have got modulated. If we see ATP3, you know that it is based on 3 out of 5 criteria. One, and the most important, is abdominal obesity, means just waist circumference. The problem with waist circumference is just that it is changing between the Asian and the Western counterparts, and the waist circumference alone is not most important, because with the new modalities defining your adiposity index, defining your visceral fat, this waist circumference alone may not be important. However, for epidemiological purposes, waist circumference of 102 centimeters in men and 88 in women is taken as the cutoff for defining metabolic syndrome. Second is the serum triglyceride level, 150 milligrams per deciliter is taken as a cutoff, or any patient with hypertriglyceridemia on medication is also taken as a cutoff. Then serum HDL, means high density cholesterol, as 40 milligram per deciliter in men and less than 50 milligram in women is taken as a cutoff, or anybody who is taking treatment for HDL cholesterol. So that is third. Fourth is blood pressure. 135/85 or anybody taking medication for the blood pressure control, then blood fasting plasma glucose of 100 milligram, or anybody taking treatment for hyperglycemia. So it has been revised to 100. Initially it was 110 because that time ADA was saying fasting plasma glucose up to 109 was taken as normal. Here I would like to pinpoint one important thing, that since metabolic syndrome was taken as the cutoff for defining those who have higher risk of coronary artery disease, the most important lipid parameter for defining coronary artery disease is LDL cholesterol. So that is not taken as a criteria in the metabolic syndrome. So that is one of the important challenges which I want to tell you. So second important criteria, defining criteria for the metabolic syndrome is IDF. So IDF is actually saying waist circumference of more than 90 centimeters in men and 88 women, HDL cholesterol 40 in men and 50 in women, TG 150 same as ATP3, and plasma glucose of equal or more than 100 milligram in fasting, or treatment of diabetes same, and blood pressure 130 and 85. And there is actually joint interim statement came, which is actually trying to combine the two criteria, IDF and ATP. I will not confuse that, but whatever criteria we're using, that these 5 cutoffs do actually underestimate metabolic syndrome. That's a very important challenge because we do not take NASH into consideration. We do not take inflammation into consideration. We do not take the procoagulant procoagulant risk into confirmation, and there are several other things. The most important thing, which is hyperinsulinemia or insulin resistance syndrome, which is the other form of metabolic syndrome. Insulin resistance actually begins with the ineffectiveness of insulin in the fat and muscle, leads to higher levels of serum insulin, and once serum insulin beta cell is unable to compensate for hyperinsulinemia, you develop hyperglycemia, and this hyperglycemia is in turn known to induce endothelial dysfunction, some form of dyslipidemia called as atherogenic dyslipidemia, and this is linked to hypertension and cytokine overactivity. So this constellation, the central insulin resistance with so many ramifications, including polycystic ovary syndrome, including type 2 diabetes mellitus and atherosclerosis. So all this gamut, including even hyperinsulinemia, all this gamut of metabolic syndrome, metabolic dysfunctions in insulin resistance should actually be called as metabolic syndrome. However, for the definitions, even what Dr. Maninder is doing a survey of metabolic syndrome in South Asian countries, they will have to define it like this. But if you actually expand your the capturing, data capturing, you will be able to find so many metabolic aberrations, and tomorrow we may be able to redefine the metabolic syndrome. So today we know the clinical features of this condition are waist circumference, blood pressure, and we do not even have acanthosis nigricans, skin tag is lipoatrophy in the definition. Only we have clinically blood pressure and waist circumference, and we have not acanthosis is not the part of it, which is the definition of insulin resistance, and even hair growth and polycystic ovary morphology is not there. We don't have the cystic ovary, Joby, all the ultrasound features, they are not there. So we have a challenge. First challenge is, do we need to redefine metabolic syndrome? And there have been expert commentaries coming in top journals of the world that they are even saying that metabolic syndrome is not an entity. If it's an entity, does an individual risk factor, and they, by combining the risk factor, does the risk change? It doesn't change. So there has been a lot of criticism of the defining metabolic syndrome. But the everlasting problem with metabolic syndrome is that every day we do research, we add a metabolic aberration. Do we every time redefine? Do we every time revise the criteria of definition? It is similar to our polycystic ovary syndrome when we make, whether it is NIH criteria, whether it is AEPCS criteria, or whether it is a Rotterdam criteria. Every time we define something new in PCOS. So these conditions have a very dicey standing. But whatever the criteria there are, the actual problem in the field is that these disorders are very common. Metabolic syndrome prevalence is somewhere in 20–30%, and it is like rising with the pandemic of obesity and diabetes in the world. It is more in males, and even in adolescents, the definitions, the problems are going up, especially when we are uncovering the risk factors. We know genetics is one risk factor. Asians that are predicted to be at higher risk for PCOS, diabetes, metabolic syndrome, CAD, all these gametes. And we also have increased visceral body fat, even though our anthropometric parameters may not be as good as Western, but we have somehow more metabolic syndrome. We defined it as thin fat Indian, or we have a thrifty genotype hypothesis for that. I won't go in detail. We may have our diet issues. We may have more carbohydrate diet. We have done some studies and we have seen that the vegetarian diet has a higher risk of inflammation, and coupled with a physical inactivity, we may have more risk of metabolic syndrome and its complications. So if we see these genetics, our fetal programming, our type of diet, and our sedentary work may be leading to visceral obesity rather than anthropometric obesity. So this is now called anthropometric undernutrition and metabolic overnutrition. So this is an intra-individual metabolic overnutrition and anthropometric undernutrition. So it is not only waist circumference, even if you might find people who have waist circumference below 88 centimeters, they may also have metabolic derangements. So with this insulin resistance, with HPA dysregulation, with atherogenic dyslipidemia, with pro-inflammation, procoagulant overactivities, several of these conditions may actually lead to redefining metabolic syndrome. We know the pathogenesis may start from genes, and insulin resistance may be the second important thing. Then we may have enzymes in the lipolysis, like if you have lipoprotein lipase, leading to abundance of free fatty acids, high free fatty acids, again going to the liver and muscle, may induce the dyslipidemia characteristic of metabolic syndrome. And if you see in this picture, there is something like that, that the fat releasing more of free fatty acids going to muscle as well as liver may be leading to this dyslipidemia, and they may also lead to a lot of abnormal sympathetic overdrive and a lot of abnormal cytokine profiles, which are characteristics of coronary artery disease, characteristics of NASH, and characteristics of strokes and cancers. And that way, these metabolic is defining a significant overburden of the metabolic disorders as well as malignancies, which are going to limit the lifespan of our population in future. So clinical implication, as I said, is diabetes. Diabetes has its own complications. Cardiovascular has its own complications. Then DVT, non-alcoholic fatty kidney disease, cancers, OSA, PCOS. We know PCOS is other form of metabolic syndrome. So even neurological issues have been defined in metabolic syndrome, and we have higher CVD 10-year risk scores by framing scores. And one of these things will shape in, you will have a significant number of issues going on to come in elderly age. But if you take even in pediatric population, These problems start in very school children, younger population. Even if your anthropometric parameters are normal, you may have significant metabolic issues coming up. So it will, whether the metabolic syndrome fits in a particular criteria or not, whether you have 1 risk factor, 2 risk factors, 3 risk factors, it finally boils down to reversing the trend of these improper risk factors in your life. So you have to undo this lifestyle, the modern lifestyle, because they are also called lifestyle disease. We have to undo these risk factors. So you should reduce your body fat overall and try to reduce your central body fat by using a physical activity protocol. You reduce the atherogenic diet. For example, this is the dyslipidemic. These are the categories. And this is how we would like to reduce the fat content. You might have to give intensive lifestyle and diet. And in diet, Mediterranean diet has been validated well, because Mediterranean diet contains more of seafood, rich in omega-3, it contains vegetables. It is not same vegetarian diet what we are used to take in India. We take our vegetarian diet is still rich in carbohydrates, deficient in omega-3, deficient in B12, and it increases more a risk of pro-inflammation. DASH diet, which is for hypertension, low salt diet is known. Low glycemic diet may have a benefit, high fiber diet may have benefit. Exercise. So accordingly, we have exercise paradigms. People have shown, they have demonstrated, there is a hardcore evidence. There are multiple meta-analyses available. I have not quoted them here. They have shown that if we have an exercise protocol from pediatric population to adults, we are going to have significant dividends in reducing the prevalence of individual or multiple metabolic risk factors. For example, in this study, they showed that if you have more than 10% weight loss, you are going to, then metabolic syndrome continues to be there in these individuals. So the type of diet, as I told you, that Mediterranean diet has been shown to be beneficial. If we adopt in our studies or even in lifestyle, this type of diet, it may have significant benefits. There are challenges in nutrition. Then you have to have a specific diet pattern depending upon the type, number of risk factors you find in an individual. So cardiovascular risk reduction in addition will be by stopping smoking in addition to these. And sometimes you may have to add some drugs like ARBs, ACE inhibitors, if you have risk factors. Even if you have glucose abnormality, you may have to give metformin, thiazolidine ions. People have used them without the glucose abnormalities also, and they have shown that this can prevent the metabolic. So we at Metabolic Syndrome Pre-Diabetes PCOS Society, one of them, welcome your initiative for capturing the data on the metabolic syndrome across. However, I would again say that knowing that the diagnostic criteria defined may miss out significant metabolic issues. For example, if you take waist circumference of 88 centimeters in women, 94 in men, that doesn't mean you have captured all metabolic syndrome. So we need to go little below that in our South Asian population, then you may not miss people. And we may be in a position to redefine these criteria tomorrow. And at our society, we're trying to look critically at metabolic syndrome, that we need to revise the definition because there is lack of clarity in definitions. We need to define multiple phenotypes because metabolic syndrome itself may have different phenotypes. It is not that you have 3 criteria. What about if you don't qualify 3 out of 5? If you have 2 criteria, do you mean that that individual is normal, doesn't have risk? So we need to look at that we may have different phenotypes. Then you have lack of consistency in having setting for thresholds for various components. It is not, God has not said that it is 88 centimeters. So we need to generate data and put new receiver operator curves to define the cutoffs or redefine the cutoffs for population specific norms. we may also have to, as I already said, look at other risk factors like procoagulant activity, inflammatory activity,
Can you
insulin,
sum up?
and so on.
Can you sum up? Because we are running short of time.
This is the last line I'm reading,
Okay.
ma'am. So
Okay.
that is even the treatment of these syndromes, we may need to redefine. And my last slide actually tells you that we have to think at it differently. Whatever criteria have been defined, they are not God sent. We need to capture data in a way that we should be in a position to understand or reinvent the disorder. Thank you very much for your attention.
Any comments from chairpersons? Dr. Ashraf, I 100% agree with you. At the end of study, we might have to redefine the metabolic syndrome. So that is where I'll need everybody to be with us till we have done the final conclusions and everything. We will be together, working together on this now, because this is the large number of data which we are going to collect. My chairpersons, any comments, please?
Pisha or me? Okay. Let me say a few words.
Just be concise because we are running short of time.
Okay, then Pisha, you do, because I already introduced him. You carry on, please.
I would like to thank Dr. Ashraf for a very comprehensive presentation. And that was very clear and the slides were beautiful. And you just, concisely try to get the message across. Thank you very much, Dr. Ashraf.
Thank you, Dr. Ashraf, and thank you, chairpersons, for your inputs. Now, the next topic for discussion is polycystic ovarian syndrome and metabolic syndrome. So, and I would ask chairpersons Dr. Suraya Rahman and Dr. Sushila Shrestha to join us for the session. Dr. Suraya Rahman is ex-head of Department of OBGYN at the CMH Dhaka and she's been advisor specialist to DGMS Ministry of Defense, Bangladesh, vice president to Bangladesh Menopause Society, vice president of SAFOMS, and senior consultant at Lakeview Clinic. Welcome, ma'am. The second chairperson for today is Dr. Sushila Shrestha. She is a senior consultant at Valley Maternity Nursing Home and Norwich International Hospital, has been vice president of Perinatal Society of Nepal, past president of NISON, past deputy director of Maternity Hospital, and past VP of NISOG. She's been master trainer for the BEOC, COC, and PMT CT. So welcome, ma'am, and looking forward to a very fruitful talk by Dr. Sandeep Khar. I request you, ma'am, to please introduce Dr. Sandeep Khar.
May I take the lead?
Yes,
yes, yes, Dr. Saraya.
So I just want to start by conveying my special thanks to Dr. Maninder for organizing this very important webinar, including all the SAFOMS members here, and also inviting me as a chairperson. And without wasting any time, I just would like to introduce the speaker. It's my privilege to introduce Dr. Sandeep Khar, who is the endocrinologist at the Army Hospital, R&R, and he's presently working as senior consultant at Asian Hospital, Faridabad, member of American Association of Clinical Endocrinology, Indian Thyroid Society, has around 30 national and international publications, 4 book publications. Predominant field of interest is diabetes and thyroid disorders. With these few words, may I invite Dr. Khara to present his paper, please.
Thanks, Dr. Rahman. Thanks for such a nice introduction. And at the outset, let me thank Dr. Maninder for this opportunity. And I'm really glad to be part of this learned panel, and all of you are here. And also, I would like to thank Professor Ashraf for the introduction which is provided, because there's a lot of data or presentation which is quite similar to his. So it will help me a lot in my presentation, and perhaps will help me run through the slides as well. So I think my slides are visible, ma'am.
Yes.
Yeah, thank you. So At the outset, let me tell you that I'll be talking about two syndromes which are extremely common. Now, Dr. Ashraf has already told about how common these disorders are, and they tend to exist quite a bit together because of the possible reasons. I'll also try to do this to the same topic. And when we talk about PCOS and metabolic syndrome, I'll be calling PCOS and METAS for future this part of my presentation. And when we talk about PCOS, this as a disease was noticed for the first time and named so as a PCO, as a syndrome by Dr. Steen and Leventhal in a hyperandrogenic female. And then gradually over a period of time, knowledge was added. And with the addition of the knowledge, what came through, the ultrasound criteria was gradually added because of the availability of ultrasonography gradually. And similar to what Dr. Ashraf was talking about metabolic syndrome, there were different guidelines which try to define this as a syndrome because it's a cluster of different diseases. Rotterdam Consensus Conference in 2003 tried to define it, and there have been multiple other aims to define it as well as advised treatment for it. There are different criteria that have also been proposed, and they share quite a bit in between. And latest has been international evidence-based guideline for assessment and management of PCOS in 2018. But what I want to talk about is a PCOS as a disease, how common it is. Now, this is one of the most commonly diagnosed endocrine disorder in a female of reproductive age group. And when we talk about prevalence, it goes from somewhere around 10% to 30%, depending on what criteria is used for diagnosis, and as well as what population is selected for that study. The thing about PCOS is that it's a disease which starts even before conception and carries throughout life. So it maybe is mostly diagnosed during reproductive age, but this has serious implications even starting before conception until the time even after menopause. The reason why it has become very significant now is, and the incidence rates are going up, is because it has got a very strong correlation with obesity. And we all know that the biggest disease at this point of time is actually obesity, which is leading on to a lot of increase in a lot of non-communicable diseases. And when we talk about South Asian population, you'll find that PCOS is more common in Asian females because of increased visceral fat. So the role of visceral fat becomes very important in etiology of PCOS. Now, when we talk about life cycle of PCOS women, the thing which I want to highlight here is that, as I said earlier, now this is a disease which has its beginnings in placenta, goes through the fetus, then childhood, then there are associated conditions which play a role. And finally, the disease starts manifesting or clinically in the adolescence. And this is where a patient gets to know about. And then when a patient conceives, there are issues there. And even at menopause, a patient, they tend to start ignoring PCOS. But the problem is that this disease is a marker of metabolic syndrome or in inflammatory state, and the risk factors, the secondary risks associated with PCOS, they tend to run and they tend to become more important after menopause. So this is the significance of the disease as such. When we talk about diagnosis of PCOS, just in the interest of time, I'll just say it's a part of three things, which there is hyperandrogenism, oligoanovulation, and an ultrasound morphology of PCO. Two of the three are considered positive. There are different diagnostic criteria, so I won't be going into details of that. But the thing is that when we talk about facts of PCOS, 50 to 70% of PCOS, they have hirsutism. 50% of PCOS are actually undiagnosed. So this is a diagnosis missed. And 5 to 10% of reproductive age group have PCOS. And when we talk about number of PCOS patients being obese or overweight, there are around 30 to 75% of PCOS patients are overweight or obese. And out of 100 PCOS patients, around 70%, they have insulin resistance. So this is a basic crux of the numbers with PCOS. And you can see here that a lot of patients are missed, and importantly, obesity and overweight is playing a significant role, and insulin resistance is there, which is playing a role there. This is one very busy slide, but what I want to highlight here is there is the pathophysiology of PCOS starts in genetics, then there are uterine factors, sedentary lifestyle, obesity, and then there is the issue of insulin resistance. I actually here, let me take this opportunity to talk a little bit about role of visceral fat in PCOS. Now, when we talk about visceral adipose tissue, now visceral adipose tissue may appear to be an inert thing, but it is one of the most active endocrine organ, and it is responsible for production of adipokines, which may be good like adiponectin, or the bad or inflammatory ones like TNF, IL-6, etc. Now, visceral adipose tissue is responsible for production of these factors, and it leads on reduction in adiponectin, increase in TNF, IL-6, and leptin. Now, this leads on to increase in insulin resistance. Now, as insulin resistance goes up, there is loss of first phase of insulin release, and body tries to compensate for this loss of insulin by in first phase or early insulin release by increasing insulin production. So there starts a state of chronic hyperinsulinemia, and this persistent hyperinsulinemia works on adrenal gland and ovary, leading on to excess androgen production, which again sets in a vicious cycle, and this leads on to PCOS as well. This hyperinsulinemia has all other roles to play as well, and obesity too, and I'll be sharing about that as well. Now, this is one slide which was shared by Dr. Ashraf as well. And when I talked so much about insulin resistance, I could not miss this slide, because here you see that insulin resistance leads on to is associated with so many constellation of diseases. And you can see here what comes here: type 2 diabetes, hypertension, obesity, IGT, atherosclerosis, dyslipidemia. What reminds you? I mean, what comes in my mind looking at all this? Any MD and any MBBS or even MD student, when he looks at it, I think his mind will go towards metabolic syndrome. And this is why these disorders, PCOS and metabolic syndrome, they are correlated, because both of in pathophysiology, both these diseases, insulin resistance is playing a very important role. When we talk about metabolic syndrome, it was reported in 1988 by Professor Riven, and initially called as syndrome X, but the name needed to be changed because there was already another syndrome X in cardiology, which was occurrence of angina chest pain in females, postmenopausal females with normal coronary angiography. So the name syndrome metabolic was added as a prefix, leading on to change in name, and now it is known as metabolic syndrome. The components have already been spoken by Dr. Ashraf. I'll say, as far as prevalence, it's a hugely prevalent disease. Around 34% of adults, as per WHO data, they suffer from metabolic syndrome. And when we talk about India, almost 1 in 3 adults in India, they suffer from metabolic syndrome. And there is a study, very good, nicely conducted study, and it has noticed that females tend to suffer from PCOS, from metabolic syndrome more commonly. People living in urban areas, they tend to suffer it more as compared to rural areas. And in India, in Northeast India, the prevalence, the higher rates of metabolic syndrome were higher as compared to other parts of India. These are different definitions. So in the interest of time, I won't be talking much about it. Already Dr. Ashraf has talked about it. And these are the things. Syndrome. So metabolic syndrome is an entity in itself, but also tells you that there are so many other diseases associated with it. And metabolic syndrome occurrence or existence of metabolic syndrome is a pointer towards development of all these diseases which we see here. And now we talk about the association between the two. Now, I think by this time, looking at the role of visceral adipose tissue and insulin resistance, it's a no-brainer that these two diseases, they tend to coexist quite a lot. But when we look at purely in the terms of number, the risk of metabolic syndrome is increased by around 11 times in a case of PCOS. So METAS is increased by around 11 times in PCOS. When we talk about PCOS with obesity, there is 14 times risk of METAS. In PCOS without obesity, 4 times risk of METAS. So even a patient of lean PCOS is 2 times. And when you look at the other way around, the occurrence of hyperinsulinemia, in cases of PCOS with metabolic syndrome, there are 2 times higher serum insulin levels. There is also a low SHBG in both PCOS and metabolic syndrome, especially who are obese. And there is a study from India done by Professor Bhattacharya, and it has shown that adolescents with PCOS have around 4.2 times higher risk of metabolic syndrome. So a lot of data, international as well as national, is there. Now let's come on to management of this disorder. Now it may appear to be very simple in the terms of that you go for weight loss and try to do that. So there is a very important role of cardiometabolic risk screening. And we should screen these patients for smoking history, weight, body mass index, waist circumference, blood pressure, and all the other parameters. Similarly, all patients with PCOS, they should be screened for metabolic syndrome at diagnosis. And if it is negative, patient must be retested once in 3 years. Now, this is a part of PCOS wherein diet management is very important. And let me take this time to share this a bit about lifestyle intervention or significance of it. Just a 5% weight loss is associated with metabolic, reproductive, and psychological benefits. In fact, 5% weight loss has been shown to improve testosterone levels, hirsutism scores, waist hip ratio, reduce insulin levels, and improve glycemic parameters. And herein, if you want to optimize even better, you can combine these interventions with behavioral and cognitive weight loss components and go for very low calorie diet or even use weight loss medications. A bit about dietary interventions. When we talk about dietary intervention for weight loss, it may appear very simple, but how you can guide your patient is, in case of PCOS, we don't need to, as of now, when we look at evidence, there is no evidence that we need to prefer one particular diet over another. But thing is that one should go for at least 500 to 750 kilocalorie of negative calorie balance on daily basis. Or one can restrict total calorie intake to 1200 to 1500 kilocalorie per day to promote weight loss. There is a very important role here for exercise interventions. When we talk about exercise, we advise our patients for moderate intensity exercise for around 150 minutes per week or 75 minutes per week of vigorous exercises. And if you want your patient to reduce weight further, you can advise your patient to go for even higher duration, like 250 minutes per week of moderate intensity activities or 150 minutes per week of vigorous intensity, or equivalent combination of both may be advised to your patient. Now, this is a combination. This is where I think a role of endocrinologist comes in, wherein first is managing the individual parameters like development of diabetes, obesity that needs to be taken care of. But here I'll be talking mainly about the pharmacotherapy which can be used here. Firstly, of course, there is metformin, which has low cost, is readily available. There's a lot of long-term safety data as insulin sensitizer, but primarily it's for off-label use. But metformin offers quite a greater benefit in patients who have higher metabolic risk. So if you have a patient of PCOS or metabolic syndrome who have impaired glucose tolerance or is from high-risk ethnic groups or has multiple diabetes risk factors, you should consider using metformin in these patients. Then there is role for anti-obesity medications, which can be added in to improve the outcomes in patients of both of PCOS or metabolic syndrome. And herein, let me talk about 2 or 3 drugs which are now available in India and are being used for management of diabetes and are also approved purely as weight loss therapies as well. One of them is liraglutide. It's an injectable therapy which can be used once daily. And there is an observational study of 84 women with PCOS and obesity, and it has been shown to cause weight loss by around 9 kilograms, and a BMI was reduced by 3.2 kilogram per meter square. This is one study. And when you use liraglutide with metformin, multiple studies have shown the weight loss is more. And in this study, it was also seen that testosterone and free androgen levels, they also reduced with the use of liraglutide. So liraglutide in the study also was shown to improve the ovarian dysfunction. Even bleeding pattern improved, but that was primarily because of weight loss rather than insulin resistance. And with the use of liraglutide in this study, it was seen that SHBG increased and free testosterone levels, they reduced. Then there is another molecule, which is semaglutide, which has recently been made available in India, and it has come in oral form. The injectable form is about to be launched in some time. And this is one medicine which has been shown to cause weight loss of around 15% at around 68 weeks. So now we have got very efficient anti-obesity therapeutic interventions with us, especially the semaglutide. If we have it in near future, injectable one will work wonders. And I think we can also take in some studies to see how semaglutide, maybe as pilot studies, how semaglutide or liraglutide can be used in patients of PCOS for improving the outcomes. Then there is a bit about Sdl32 inhibitors. Now these are again anti-diabetic drugs, but this is a meta-analysis of 4 trials of 158 patients with documented PCOS. Their SDL32 inhibitors, they cause weight loss of around 2 to 3.5 kilograms. And they have been shown to improve metabolic perspective in the terms of reduction of HOMA-IR and fasting plasma glucose and improvement in DHEAS levels. There is experimental role of inositol, so that can be used as a safe option. This is an area of research whereas metabolomics may be used, so assessment of aromatic amino acids, branch chain amino acids can be used in order free fatty acids to predict future risk of metabolic syndrome in young PCOS as well. Then there is a bit about epigenetic diets and gut microbiota. When we talk about epigenetics, I think we all know it refers to any factor that affects genes without changing the primary DNA sequence or gene type. Let me talk a bit about epigenetic diets. There are small studies which have shown that increasing the omega-3 PUFAs, they may have epigenetic benefits. There are some small studies showing role of green tea turmeric, so which may be part of small studies with dietitians, it may be planned there. And then there is very important role play of gut microbiota. I think this is one part which has been missed, or maybe I won't say missed, but kind of neglected in endocrine disorders or metabolic syndrome or PCOS, because this inflammation is playing a very, very important role in PCOS as well as METAS. And gut microbiota plays a very important role in increasing inflammation. So maintaining good gut microbiota by using probiotics or probiotics should be a part, and maybe can be taken up as a small study to see how the patient of PCOS or metabolic syndrome respond to these interventions. With this, friends, I would like to thank you all for patient hearing.
Thank you, Dr. Maninder, for giving me opportunity to chair the session. And I also thank Dr. Sandeep for giving excellent presentation. Now I think we have a lot to cover today, so I think we should go further. Thank you.
Dr. Sandeep, I think you have covered two, three points very importantly. That one is the in utero origin. That is very important. So prevention starts from in utero origin. Secondly, what you have talked about is the role of weight reduction drugs, which is very important because even 5% weight reduction can lead on to change in the biochemical and metabolic parameters is there. And then what is important, which is coming, I think, in metabolic syndrome in the future is role of epigenetics and genetics. And of course, I think the role of pollutants and endocrine disruptors is going to play a major role. So I think because of shortage of time, we'll move ahead now, Dr. Priyanka. And I think because we are into such a mesh of a metabolic syndrome, where one is encroaching on the other, so the speakers can also keep, I think, taking advantage of that and keep to the time also. Thank you, Dr. Sarab. It was a wonderful talk.
Thank you, Dr. Suraya Rahman, Dr. Sushila Shrestha, and Dr. Sandeep Kar for that very informative session. The next topic is the correlation of menopause and metabolic syndrome. I would like to invite the chairpersons, Dr. Kesang Diki Besta and Dr. Sambul Sohail. Dr. Kesang Diki Besta is a senior consultant at Tribhuvan University Teaching Hospital, Maharajganj Medical Campus, Kathmandu, Nepal. She is an MD program coordinator, a member of Research, Audit and Curriculum Development Committee of MMC, President of MESON, in charge of the SAFOMS newsletter, co-editor of the Nepal Journal of Obs and Gynae, and is the recipient of many prestigious awards. She is an advisor and founding member of the Lo Gyalpo Jigme Foundation, I hope I got the name right, social organization for working to uplift health, education, and cultural conservation in Nepal. Welcome, ma'am. The second chairperson for today is Dr. Sambul Sohail. She is a professor in Obs and Gynae at Ziauddin University, Karachi, Pakistan, and General Secretary of Pakistan Menopause Society, executive member of SAFOMS. We welcome you, ma'am, as well, and I request the chairpersons to introduce today's speaker for the topic, Dr. Sunila Khandelwal.
Thank you for your introduction. And thank you also to Dr. Maninder for inviting us and to chair this wonderful session. And so now we are coming to the real crux of the metabolic syndrome and the menopause. And we have Dr. Sunila Khandelwal, a very senior consultant gynecologist. She's been the Director of Midlife Women Healthcare and Menopause Center, Fortis Hospital in Jaipur, India. She's also the past Treasurer and Secretary General of the International Menopause Society and the past President of Indian Menopausal Society. She has had teaching experiences for the last 38 years, and she's been on various professional positions and peer organizations. She started the first menopause clinic in Rajasthan and has been the founder of the Jaipur chapter of IMS, and also health curriculum and management of menopause inducted credentials of the Indian Menopause Practitioner exam. She's been a founder editor of the Journal of Midlife Health, and she's received advanced training in menopause management and laparoscopy, and she has widely lectured at various universities and centers and conferences, and she has received many awards, and related to menopause, the Award of Excellence by the International Menopause Society. And we are very glad to have Dr. Sunila Khandelwal to talk to us about menopause and metabolic syndrome and its correlation.
Thanks, Dr. Maninder, for involving me, and sorry for the delay. But I just bring greetings from India to all my SAFOMS friends. It's nice to see you all. And the job given to me is actually the title of our survey and this whole research. So it is a big responsibility for me to cover this topic in a nicer way. But of course, there is limitation of the time. So metabolic syndrome, as we all know, that it's an epidemic increasing worldwide, and we have covered, I will not repeat, my previous speakers have done a good job, and they have simplified my job, but my area will be to exactly to emphasize what is the exact correlation of metabolic syndrome with the menopause. And so these the prevalence appears, as we all know, it is more in Asian countries than the Caucasians, and there is postmenopausal status is associated with 60% increased risk of the metabolic syndrome. The learning objective of my talk will be to review the features of the metabolic syndrome that emerge with estrogen deficiency, to understand the metabolic changes of the menopause, and also recognizing the women at risk for timely, appropriate interventions. Of course, we as a clinician should increase their awareness of the metabolic derangements associated with the syndrome and consider them when we are using MHT in clinical practice. We have to consider them when weighing MHT options, and also while considering the management of individual parameters of the syndrome. So we are facing a challenge to understand the pathogenesis, as my previous speakers were taken into account of all these things, but we have to prevent it either at the population level or at a visual level or in country or region. So let us see what are the key metabolic issues in the women, and especially in postmenopausal women, and why should we focus on aggressive early therapy and how we should achieve the targets. That's the ultimate aim. Of course, now we already know about the clusters of the metabolic condition, and of course, I would just emphasize here, it was first described at Vague in 1956 as Syndrome X. We already know about the linked metabolic abnormalities and resulting conditions, but these adverse metabolic changes occurring at menopause transition as a consequence of declining ovarian steroids has to be emphasized, which increases the risk of CVD and stroke 3 times, and diabetes mellitus type 2 5 times. These organizations have given the criteria, and I'm not going to discuss this, but World Health Organization and other international organizations have proposed a harmonized definition, and of course this is which where I will like to cover. The WHO criteria has included microalbuminuria, but I think Maninder, it's good we have included, we have categorized, we will be categorizing metabolic syndrome, harmonization definition, and especially IDF criteria. I will not go into detail. Coming from the country like India, we have average prevalence about 26.9 by the original 83 criteria, 32.7 by modified NCP criteria, and 38.2% by IDF criteria. Let's see what we come out with the result with South Asian countries. The factors with the metabolic syndrome in Indians has given us an idea that the early life adverse changes like early menopause, in addition to all other complex situations which are determinants of the metabolic syndrome and causes various implications, is most important. And I think this was the earliest study which I have done in 2009, where we have concluded the obesity and menopause clinic, and we concluded that the postmenopausal obese women have greater risk of developing syndrome X, in addition to the other factors which increase the risk of CAD. This particular study, Pan-India study survey done by the leadership of the Dr. Maninder Ahuja itself, which further signifies that there is a change in the, there is rising trends of BMI, waist circumference and weight in Indian females. Also, that all gives us an idea that just something which is related to estrogen, and as menopause is associated with estrogen deficiency related decrease in insulin activity over the time of menopause, with reduction in the glucose tolerance and hyperinsulinemia. Postmenopausal women, we know they have a higher lipase activity in gluteal and abdominal adipose tissue, and lipolysis response is also lower, which predisposes to fat disposition. And this is further aggravated with reduction in the exercise capacity and activity, which contribute to the reduced lean body mass and increased central adiposity with menopause. The interaction of the genetic and environmental factors with raised intra-abdominal fat increases the insulin resistance, increased free fatty acid, decreased adiponectin, and this further leads to the increased ApoB secretion and resulting into triglycerides rise, and also decreased hepatic lipase, which leads to the raise in the small dense LDL and decrease in HDL. So this is the interaction of the genetic and environmental factors. Dr. Maninder was talking about that we have to come out with the pollutants and all those factors. So I think there is a very good correlation which we can make out with increased visceral fat and environment and genetics. We all know that there is an android fat distribution with metabolic syndrome, which predisposes hypertriglyceridemia, low levels of HDL cholesterol, and all high-risk factors of CHT. The studies have shown that there is direct effect of the estrogen with the redistribution of the body fat towards an android distribution. And this has shown to be more important risk factor than just obesity. So even normal weight can have metabolic syndrome because of the redistribution of the fat. This is the important thing which came out. So why do these women put on weight? Because the 60% of the postmenopausal women tend to get weight with shift towards the visceral fat distribution. So whether they eat more or they do exercise less, or there is altered metabolism, or the combination of the above. But there is increased abdominal fat and unfavorable, which is an unfavorable risk factor despite of unchanged total body weight, which was I was talking about. So which we have to keep in our mind. And you can see here very nicely depicted, there is increase in the visceral fat and the subcutaneous fat, which is because of the decreased estrogen and also the inflammation caused by this dysfunctional fat. This increased visceral fat leads to, there is, as already I've talked about, decreased adenonectin, increased TNF, degradation of the apolipoprotein protein B, and increased hepatic lipase activity, resulting into the blown picture of the metabolic syndrome. So the basic cause could be the increased visceral fat because of the estrogen insufficiency or deficiency. So menopause results in adverse changes in several metabolic risk factors, loss of ovarian function with adverse lipid profile, elevated LDL, oxidized LDL attracts the macrophages, which is the production of the foam cells, which cause atherogenic process, and also there is insulin resistance. Coming to the hypertension, which is again because of the direct effect of the estrogen deficiency, is associated with increased hypertension at menopause, and there is deterioration of the vascular function. And the Framingham study has already found that there is a 4-fold rise in CVT in 10 years following natural menopause. So there is definite correlation because of the alteration in the coagulation factors, which has been described at the menopause, like serum fibrinogen, factor 7, antithrombin, plasminogen activator inhibitors, which are highly predictive of IHT, and which they are all significantly increased. Coming to the hyperinsulinemia, of course, again, because of the decreased insulin sensitivity specifically, there is increased risk 3 times of metabolic syndrome versus man, and there is increased risk 2 times for PCSD and increased risk 2 times for the MI. So whatever oral intake of is there, the free fatty acids coming from the impaired oxidation fat from the muscle fiber, from the abdominal fat deposits, they all lead to the hyperinsulinemia and very significant increase in the free testosterone level because of the low synthesis of the serum human binding globulin, and this leads to central obesity and disrupt the glycemic control, and all the 3 things, hypertension, diabetes, and CAT precipitates out. There is possible causes of the androgen, altered androgen estrogen ratio is very important, which has come out as in recent studies, as there is androgen predominance in menopausal transition, which causes central obesity, and with genetic predisposition and environmental influence, it ultimately ends up with the metabolic syndrome. The Korean study was done in 2008, which signifies that the postmenopausal status is an independent risk factor for metabolic syndrome and all individual components. And so, another study with the cardiovascular health study have shown that the higher levels of the testosterone, as there is predominance of the androgens, is associated with metabolic syndrome. And so it is important that to investigate whether testosterone is a marker or the mediator for the cardiovascular disease in this population, and which is further area of research. The Swan study was done, which showed that there is increase in the bioavailable testosterone and decrease in the sex hormone binding globulin levels. And this study has concluded that 13.7% of the women had new onset of metabolic syndrome, and relative androgen axis during the menopausal transition predicts the incidence of the incident metabolic syndrome in midlife of the women. So this relationship specifically, I would like to emphasize that they have shown that this relationship was independent of ethnicity. So whatever ethnicity, we are talking about SAFOMS countries also, this goes same with this area also, that there is testosterone dominance. This longitudinal analysis of changes in the weight and waist circumference in relation to the incident of vasomotor symptoms, and it was done in Swan study again in 2017, and which concluded that the concurrent BMI and waist circumference were positively related to the incidence of the VMS in early menopause, and negatively related to late menopause. Maintaining healthy weight is thus very, very important in early menopause, which help to prevent metabolic syndrome. Again, oophorectomy, the incidence of oophorectomy is rising, whether it is because of risk reducing or we are associated with hereditary or breast ovarian cancer. So they have found that the higher incidence was found around 36.5% found in patients in 5 years follow-up. Again, the hysterectomy also is associated with increased risk of metabolic syndrome. And you can see here that even if you conserve the ovaries, the hysterectomy is associated with increased risk of cardiovascular and metabolic condition. So day in and day out, our surgeons, colleagues, even gynecologists, they are doing hysterectomy. So in fact, indirectly, we are increasing the risk of metabolic syndrome, specifically if we are doing it before the age of 35. And in these associations, if these associations are casual, alternative to hysterectomy should be considered to treat the benign gynecological condition. And all that we have in our basket of armamentarium, we have to manage the underlying cause, manage the lipid and non-lipid risk factors, and treat the LDL first, mind you, and then address the elevated triglycerides and low HDL. So I'm not going to detail of the management, but the clinical practice guidelines by Indian Menopause Society published in GMS clearly says that, of course, in obese class 2, the lifestyle plus drug therapy plus surgery, if comorbidities exist, should be advocated, and class 3, of course, the surgery. So MHT, coming to again, the prescription of the MHT supports the hypothesis that the transdermal estrogen treatment has a protective effect against the risk factors of the metabolic syndrome, and this the International Menopause Society has given the guidelines that the MHT has potential for improving the cardiovascular risk profile. It has positive effects. And also the World Menopause Month 2014 white paper suggests all these guidelines related to the obesity and prevention and treatment, including exercise, complementary alternative approaches, pharmacotherapy, and MHT. And they have clearly mentioned that it reduces central adiposity, insulin resistance, and onset of diabetes, and does not cause weight gain. So we should keep in our mind, if they are taking MHT, it's good. And it's good, the column is there in this our survey also in the protocol, that whether they are on MHT or not. So this gives me a little bit good feeling about our own country, where we are practicing yoga. And recently my paper published, a review article published in Climatry, says that yoga-based life interventions can effectively prevent and retard the progression of the cardiovascular metabolic disorders. And on this basis, we have also done a survey of incorporating yoga in the management of menopause, where we have, I'm happy to notice that the 75% of the participants reported that they are advocating yoga for metabolic syndrome patients. Recommendations by International Menopause Society published in 2016 have clearly shown the evidence of MHT, pooled data. The trial 107 trials conducted that are charted related metabolic syndrome features. They are reduced, and the effects were diminished by addition of the progesterone, which is again has to be considered, and grade A recommendation were being given. So we have to assess the risk of CAD, address the modifiable risk factors, keep tabs on all the parameters which are included in our survey. Good, we have included all those. We will certainly come out with and consider the preventive medications. This specifically, I'm happy Dr. Maninder put this forward, that we fat but fit only transition state and the risk pathway. So it is not that if someone is metabolically healthy obese, she will be prevented from the metabolic syndrome. It is just a transitional state between that and the overt pathophysiology. So it is an opportunity for weight reduction. So both metabolically healthy obese as well as metabolically unhealthy obese individuals should be treated. Now, the most important upcoming challenge, which I feel I must discuss in my last slide, that the current evidence suggests that the features of the metabolic syndrome present before the menopause, we are correlating, just think that they are present before the menopause, like insulin resistance, small dense particle LDL, elevated plasminogen activator inhibitors during perimenopause may be the carriers for the genetic predisposition. That means they are masked by the effect of the estrogen and unmasked by the menopause. So once there is estrogen deficiency, this genetic predisposition, the features were not evident, clearly was shown, they will come up. So this subset of women requires targeted management to prevent the future cardiovascular risk. So certainly our project, this research will give guideline to this particular subset of the women. To summarize, many features of the metabolic syndrome emerge with estrogen deficiency. There is accumulation of excessive metabolic abdominal fat. Menopause is a cardiovascular risk factor. Endogenous estrogen appears cardioprotective. And of course, we need to have more research clearly needed to further characterize the mechanism by which the women develop these metabolic changes with menopause. And to South Asian countries, there is a need to represent because South Asian countries, they represent 1/5 of the total population, and we don't have to overlook all those things. Early metabolic syndrome now has been shown in the South Asian pediatric population already, and which suggests metabolic programming and perinatal influences may likely to play the substantial role. So new ethnic specific guidelines and prevention strategies should be applied for the clinicians to their South Asian countries. So finally, I conclude that screening of menopause is an ideal opportunities, and the future areas of research is warranted to understand the gene environmental interaction for observed discrepancies between the Asian and Caucasians. And this particular field challenges clinicians to adopt strategies for managing menopause that do not disturb or exacerbate the metabolic dysfunction, and if possible, rather improve. So for physicians, we have to look for the factors which may lead to the full-blown metabolic syndrome. We have to discuss the women risk profile and ensure accurate risk perception, and focus on the prevention of the weight gain, and develop long-term effective community-based preventive health plan by encouraging combination of the exercise, dietary modification, behavioral therapy, and pharmacological intervention with appropriate use of MHT. Thank you so much. With this, I invite you to the World Congress. Working in the board, it's my pleasure to invite you and for the World Congress. And block your dates for 26th to 29th October, and thank you for your kind attention. You can register now. The registration is open, and send the abstracts too. Thank you so much, and once again, thank you for giving me the opportunity for this, my area of interest, the most important topic in today's context.
Wonderful presentation. Comments from the chairpersons, please.
Thank you, Dr. Sunila, for your wonderful presentation. And I think ma'am has rightly shown the relationship between metabolic syndrome and menopause and how it's so closely related. And she's talked about not only the weight gain, but then the redistribution of the weight, which is very important. And two features, that is the weight gain and insulin resistance, are, as she's rightly shown, are the key components. And I think that the last part where she said that if we could diagnose, or if there could be factors where we could test and find out about metabolic syndrome even before menopause, then it would be really something. And that is an area of further research. And thank you to Dr. Sunila. And just to show that the importance of metabolic syndrome, we have come up with, the Maison has come up with this brochure on metabolic syndrome. This is for our patients, and it's both in Nepali and in English. So we are distributing.
Amazing. That's amazing. I think you are the pioneer in bringing this.
Yeah,
that's amazing. I think I would like you to share this to me, to my email ID. Okay.
Okay, sure, ma'am. Okay, so
I will love. This is my most passionate area of work.
This is
thank you so much.
First step we have taken, Dr. Dicky. Thank you very much. That means we already have taken that first step forward towards metabolic syndrome.
Yeah.
Thank you.
I'm
Thank you so
really
much.
happy.
That is
Thank
what
you.
we have to do, create an awareness.
Yes, thank you. So as it's both in Nepali as well as in English, so for our patients.
And Dr. Sunila, your presentation was wonderful, really what we wanted. And I'm glad that most of the points we have already covered in our research format, so that we will be coming out with definite solutions or some answers to future.
Only one thing I forgot to just comment. I think the slide was missing. I would appreciate, Maninder, if you add in the history of depression, because there is definite studies are coming where there is depression when menopause and the metabolic syndrome precipitates out. Because maybe eating behavior. So in the past, in the personal history, I think we should add the depression, history of depression.
Also, I think also sleep disturbances also, no?
Yeah.
Sleep and sleep disturbing.
It's like Maninder, it's like forebrain syndrome.
You are not going to answer all those questions, and I will be left with just 10-20 forms only.
Okay.
No, it's just like
important.
It's just like forebrain syndrome, which lends into the metabolic syndrome, vasomotor symptom, which lead to the sleep difficulty, and sleep difficulty leads to depression. So we have to just cover this forebrain syndrome.
Yes, all these factors are important, I know, but I want to have the subsequent studies which will be coming after this study.
Okay.
To make these factors available. More and more work will be done. I am 100% sure this will be the most favorite topic of all the teachers in the medical colleges for their PG students, because this will be easily done and the most need of the hour. So we move to the further. Next, Dr.
Thank you. Thank you, chairpersons and Dr. Sunila, for such a wonderful, lively interaction. The next talk endeavors to explore the difference in the pathophysiology and the expression of metabolic syndrome in South Asian population. So for this session, I would request Professor Rubina Hussain and Professor Rubina Sohail to join us as chairpersons. Professor Rubina Hussain is the editorial board member of the Pakistan Journal of Medicine and Dentistry. She is professor in gynecology and obstetrics at the Ziauddin University and Hospitals. She is the president of the Pakistan Menopause Society, member of Senate and Syndicate of the Jinnah Sindh Medical University, life member of the SOGP, member of the Asian Pacific Menopause Federation, member of the National Committee on Maternal and Neonatal Health, member on the Association of Mothers and Newborns, member of the Health Research Advisory Board, and life member of the Pakistan Urogynecologist Association. Dr. Rubina Sohail is consultant OBGYN at the Hamid Latif Hospital, Lahore. She is a champion in sexual and reproductive health rights, a pioneer for KMC in Pakistan, chair for the FIGO Committee on Women Facing Crisis, the past president of the SAFOMS, and she is a widely published author. And she has also achieved the prestigious Young Gynecologist Award by the AO-FOG in 1995. So we welcome both our chairpersons, and I request the chairpersons to introduce Dr. MDP for the next talk.
Thank you very much for this detailed introduction. It is my proud privilege to introduce to you our speaker, Dr. MDP Gunaratne, who's a senior gynecologist from Sri Lanka. He's a senior consultant. He has held many posts in SLCOG. He is the founder president of Menopause Society of Sri Lanka. He is the past president, South Asian Federation of Menopause Societies. He is a member of WHO Expert Committee on Maternal and Newborn Health in Sri Lanka, 2004. He has presented many papers at national and international conferences and symposia. He has delivered orations at national and international menopause conferences. He is the author of many articles at national and international journals, and he has authored 2 books on menopause. It is my proud privilege to invite Dr. MDP Gunaratne to talk about, is metabolic syndrome different in South Asia? Over to you, sir.
Thank you very much, chairpersons. Thank you, Maninder, for organizing this seminar. Only thing is, I must apologize that my laptop didn't open the Zoom, and then I am using Dr. Piyush's laptop. Secondly, I also apologize during the process. I lost some slides, so and I'll be talking about that during the period. Right. Firstly, I must mention there are many similarities. Firstly, before we talk about the differences, my talk is about actually metabolic syndrome in South Asian women. Is it different? Well, there are similarities because metabolic syndrome is metabolic syndrome wherever it is. And the main criteria is similar: obesity, dyslipidemia, dyslipidemia, and hypertension. It increases with menopause. It increases risk of coronary heart disease, diabetes, and also increase all-cause mortality and cardiovascular deaths. And of course, there are many differences. I lost some slide again. Never mind. There are some similarities in the sense that there are differences in the South Asian women because it's different from now the metabolic syndrome of South Asian men, and also different from other women of the region, South Asian region, especially the Far East, and also from the Western countries. South Asian women, as you know, there are nearly about 375 million postmenopausal women are presently present in the South Asian region, and it's a distinct group because they are connected not only genetically but also culturally and diet-wise, and many ways they are connected, and therefore we have different even clinical pictures are different. For example, polycystic ovarian syndrome, obesity, metabolic syndrome, diabetes, non-alcoholic liver disease, they have malic osteoporosis. These are fairly common in in women in the South Asian region. And there are among the other, of course, differences. There are, of course, regarding the criteria for definition of the metabolic syndrome, because women at a lower BMI and lower waist circumference, they are ability to get diagnosed as metabolic syndrome. And the other thing, of course, is there are other factors like prevalence, and of course prevalence, as you see here in this slide. If you concentrate on the last column, the International Diabetic Federation figures, depending on the figures, most of the other Asian countries, like especially the Far Eastern countries like China, Taiwan, you find the metabolic prevalence of metabolic syndrome is low. Then, of course, the Western countries is a slightly higher, and in the highest, of course, in the South Asian region, Sri Lanka as well as India, that's nearly 48% in the females. So, the second point about this slide, of course, is that the prevalence among the males and the females is similar in some of the other Asian countries, so-called Southeast Asian, like China and Taiwan and so on. It's very much similar in the prevalence in the metabolic syndrome in the males and females, men and women. While in the case of similarly in the Western countries too, one finds their similar prevalence in the males and females. What India and Sri Lanka, as you notice, you find marked increase for the prevalence in the women to 38.4 in Sri Lanka and 48.2, which is about nearly 1 in 2 women. That's increased when compared to men. So this is which is more clearly seen here. Of course, there's highest in India and of course in Sri Lanka, which is because these of course depends on the ages that are used, and again highest in the South Asian region in women. So this particular study was done in Sri Lanka, and it's a community-based study, and it's more or less a national figure because it included nearly all the provinces, and a large number of men and women were recruited. And one would notice that, firstly, the gradual increase of diabetes prevalence, metabolic syndrome prevalence as age advances. And secondly, in the women get a metabolic syndrome at a lower age than in men. Women get a metabolic syndrome at low age. Even at 40 years, you find 35%, while in the males is 19.4%. Next point to mention is after menopause, there's a marked increase, gradual increase, and then it increases even after at 70 years, it's 46.5% of the females. While in the case of males, generally after 50 years, it plateaus, and as a result, there is less increase. This is in contrast to some of the other studies by Das and others, but we find that definitely there's much difference of the metabolic syndrome in men and women in South Asian region. Now, another thing, of course, there are many determinants. Of course, as some of the slides are missing, I'll be talking about it only. And one find many determinants of metabolic syndrome. As many of the speakers mentioned, there are genetic factors, and of course, it's inconclusive to see to find out exact one particular locus for metabolic syndrome. There are many other loci, especially SNPs, single nucleotide polymorphisms in other like hypertension or obesity or diabetes. There are many other loci available are present, and these are of course present not only in the Western countries as well as South Asian region, but this is the cumulative effect of these genetic factors of individual criteria that may be the reason why metabolic syndrome is higher in South Asian women. Next, of course, is the physical activity. Physical activity is very much reduced. In the Interheart study, it has been shown that South Asian women had lower physical activity, especially in the urban areas. Then there's psychosocial stress. The mental stress is another major determinant of metabolic syndrome, and one find again stress is again higher in the especially urban women in managing their lives. Then of course we come to diet, and of course the diet again is play a major role as a determinant of metabolic syndrome. In the South Asian has a special diet because, as I mentioned, increase in carbohydrates. They have increased saturated fatty acids in our diets, and of course omega-6 polyunsaturated fatty acids are increased. So trans fats, as we know, with most of India, they use vanaspati and so on, and they all increase trans fats. And of course, in our diet, we find reduced monounsaturated fatty acids and of course omega-3 polyunsaturated fatty acids. So all this lead to increased insulin resistance. So that is diet playing a major role, of course, that is one of the reasons why it is different in South Asian region. Then of course there's visceral adiposity. This of course, sorry. Then there's visceral.
Slides are not moving, Dr. Gunaratte.
Yes.
Slides are not moving.
I have lost some slides. I told you.
Okay. You remember. Okay.
Those slides by memory.
Yes. Okay.
So there is some other problem, of course, is visceral adiposity, and there is thrifty genotype and thrifty phenotype, and we know this that is in the intrauterine region, in the intrauterine part time, there's increased eating, increased calorie intake, and also similarly postnatally also there is increased excessive feeding. It has been shown, for example, that we tend to when after in the first few years we tend to somehow tend to put our children into the higher curve, higher anthropometric measurements. And as a result, we'll be overfeeding some of the children. And this is one of the reasons why there is increase of visceral adiposity. Then, of course, there is other main problem, of course, is urbanization. And these are then the result of the increased adiposity. One finds these various adipokines. There's increased adiponectin, increased leptin and resisting and CRP, while there's reduction of adiponectin. And this is, of course, resulting in increased insulin resistance and endothelial dysfunction, leading to coronary heart disease and type 2 diabetes. Now, if you look at the comparison, one were to comparison of leptin levels in Pune and London, this is a study done some time back, and newborn pairs are matched for birth weight and the gestational age. One finds that the insulin levels were higher in the newborns in Pune when compared to those in London, very much higher. So is leptin, insulin and leptin were much higher in the newborns compared to those in the Western countries. So this is another thing that one will notice. Same thing with the girls and boys. Again, one finds the girls have a higher levels of proinsulin, 35 when compared to 25. This is okay compared with birth weight and gestational age. So South Asian, again, women will have a higher level of proinsulins and higher levels of leptin to begin with. Right. And the comparison of leptin in Pune and London we mentioned, that's right. Sorry. And the leptin levels in Pune and London, again, you find increased insulin. I'm going back, sorry. When compared to, how about in the adults? Adult South Asian women as well, but one find, again, adiponectin was less when compared to the white Caucasian women. Is nearly half of that adiponectin in the South Asian women. So it indicates that there is increased visceral adiposity, and all this lead to increased insulin resistance and coronary heart disease. Right. How about LDL? The other factors are the LDL and the HDL. LDL is not mentioned in the definition, but one will find HDL is 0.22 when compared to 0.33. So is LDL, especially the triglycerides are increased, and especially the very low density lipoprotein, which is more atherogenic, one find is nearly double that of white women in the Asian Indian women. So all this indicates that there's a definite marked difference as far as the risk factors are concerned in the Asian women. Right. Another major problem that we see, of course, is the urbanization. Urbanization, what I mean is not only that villages become towns, but there is migration of people into the urban areas and slums. And this, of course, creates many clinical problems. There is increased stress, reduced physical activity, mechanization. And when this particular study shows prevalence of metabolic syndrome in rural areas is less 24.7 when compared to urban, which is very much higher. Here, of course, I don't have the slide. I must mention that there was a study done in South India. There's a study about studied the BMI and the waist circumference in women and men in Kanchipur, especially women in Kanchipuram and the peri-urban villages. And it was repeated after 6 years. I remember it's 2006. And one found that there was not much increase of BMI and the waist circumference and the presence of diabetes in the villages, while in the city, of course, there's marked increase of the waist circumference and BMI. So these are the result of urbanization, and the urbanization is very much higher in South Asia. Right. And then another major problem that we see is vitamin D, and vitamin D has another determinant. And in the West, you find in the top line is about 28, which is near normal levels, while find in South India, in India, Sri Lanka, and so on, it is moderately and mildly deficient, and Pakistan is 8.8, which is extremely low. So low vitamin D levels is another determinant which has caused metabolic syndrome in South Asian region. Now, there are many other things that I used to say. For example, there is, how about the complications? The complications, of course, are again higher in South Asian women than in other regions. Coronary artery disease mortality is higher. Stroke mortality is higher in South Asian women than in other regions. Then diabetic complications too, again increased. Southall study done some time back showed there's increased all-cause mortality, increased mortality due to coronary heart disease, and so on. So complications are higher in South Asian women when compared to men. Now, are there any differences in management and prevention in South Asian region, South Asian women? Well, yes, unfortunately, yes. For example, you find in South Asia, women are supposed to they are not given a major role, because men are given predominantly being preference in many aspects, especially in health actions. So now women, when they get chest pain, they are taken last to the hospital, and there are many deaths due to coronary heart disease among women in the ambulances, because they are taken last, because men are given preference to be taken to hospital when they have coronary heart disease. Second problem, of course, is that they are less diagnosed. We know there's microvascular dysfunction disease in the coronary arteries in women, and this is worse in South Asian women because lower anthropometric measurements, and they have smaller microvascular disease, and as a result, one find they are not diagnosed, the ECG does not show, and angiogram may not show, and therefore they are often not diagnosed, and they are come at the last moment, and they end up in increased mortality. Similar thing, of course, is the coronary in the strokes. There are the cerebral vessels also. There are smaller vessels which are involved. Mortality is higher. And the other thing is, have we prevented all these years? Have we prevented metabolic syndrome? Prevented cardiac and diabetes in these cases? No. All the studies have shown over the years there has been increase of coronary heart disease, increase of diabetes, increase of metabolic syndrome. So our actions as far as health measures are concerned has been not up to the mark, and we should really see that there is some action to be taken, especially to improve prevent metabolic syndrome in women. So in concluding, I must say that there are differences, of course, not only in prevalence, there's also differences in the effects of the various risk factors. And lastly, there are increased complications of metabolic syndrome in South Asian women. Thank you very much for listening.
Dr. Gunaratne, thank you very much for an excellent presentation. And the presentation actually highlighted the difference between the South Asian and other populations in terms of the metabolic syndrome, highlighting the fact that how the lifestyle, obesity, urban and rural divide, the low vitamin D levels, they play a very important role in determining the effects of the metabolic syndrome and increasing the prevalence of metabolic syndrome in the South Asian population. And not only are these causes significant, but the complications are also significant, and the South Asians are more prone to complications, resulting in greater morbidity and mortality. With this, I'd like to thank you, Dr. Gunaratne, for highlighting this very important issue for us. And I think all the presentations have set the stage for the panel discussion. And last of all, I think I thank Dr. Maninder Ahuja for keeping us all focused during this session with the brilliant presentations that she has organized. Thank you very much.
Thank you, Rubina. First of all, I must thank Dr. MDP Gunaratne for being here. Sir, I'm really honored by your presence. And if I tell you the truth, I was initiated into metabolic syndrome by one of your talks only, and I remember them by heart. So I remember your slides also.
That was in Amritsar many years ago.
So I think though we are running out of late, but the discussions have been so good, and all the speakers have been so excellent. And because obesity was the last part, so that's why I had given that important topic to Dr. Rakesh Sahai. Anyway, over to you, Dr. Priyanka. And Dr. Gunaratne, you have to spearhead the research project in the Sri Lanka. I'm depending on you because you can take them with the whip that they have to do it. How you get it done? Because I know your circumstances are not very favorable, but we wish that they become favorable for you very soon. That is what we can all wish for the Sri Lankan people and Sri Lankan healthcare professional and everybody.
Yes. You have reflected our feelings, Maninder. Everybody feels the same for Sri Lanka, and we are worried and praying for the people of Sri Lanka and our friends there.
Yes, we are worried, and we are thankful that you have, despite your unfavorable circumstances and challenges, you made it possible today. I am really honored and appreciate the fact. Dr. Priyanka, please.
Thank you, Chairperson and Dr. Gunaratne for such a wonderful talk. The next topic is visceral fat as an endocrine organ, and the chairpersons for the session are Dr. Sanat Akmimana and Dr. Shobna Mohandas. Dr. Sanat is consultant obstetrician and gynecologist at Colombo South Teaching Hospital, president of the Menopause Society of Sri Lanka, and chairperson of CPD for Sri Lanka College of Obstetricians and Gynecologists. Dr. Shobna Mohandas is consultant gynecologist and laparoscopic surgeon at Sun Medical Center, Thrissur, Kerala. She is present for the Menopause Society for 2022-23, Senior Vice President of IMA Thrissur, Vice President of Midzone Kerala WTWIMA, Vice President, Secretary General Website Committee, Quiz Chair for IMS. She's past member of FOXY Endocrinology Committee, Food and Drugs Committee, South Zone Coordinator for FOXY Hysteroscopy Workshop, and she's a prolific author and a contributor to many textbooks. We welcome both our chairpersons, and I request them to introduce our speaker, Dr. Rakesh Kumar Sahai.
Good evening to everyone, and thank you very much, Dr. Manindra, for organizing this webinar, a very useful webinar, and also inviting us to be a part of it. Thank you very much. The speaker is Dr. Rakesh Kumar Sahai, MD, DM, FACE, FICP, Professor and Head of Department of Endocrinology, Osmania Medical College Hospital, Consultant Endocrinologist, Science Endocrine and Diabetes Center, Amipet, Hyderabad. He is the President, Endocrine Society of India, Vice President, South Asian Federation of Endocrine Societies, Section Editor, Topical Endocrinology, Endotext, Online Textbook of Endocrinology, Editorial Board Member of IJEM, National EC Member, RSSDI, Organizing Secretary, RSSDI National Conference 2016. He has won many awards, Fellowship of National Academy of Medical Sciences in 2021, Fellowship of American College of Endocrinology in 2009, Fellowship of RSSID 2015, Fellowship of Indian College of Physicians in 2006, Fellowship of Indian Academy of Clinical Medicine 2008, First Senior Lectureship, Oration of Association of Physicians of India for 2008, Best Teacher in Medicine Award from Government of Telangana 2018 on Teachers' Day. He has many publications, over 150 publications in various national and international journals, and authored chapters in various textbooks and monograms on diabetes and endocrinology. Dr. Rakesh Kumar, it's over to you.
Thank you, chairpersons, for the kind words of introduction. And at the outset, I would like to thank Dr. Maninder Ahuja for organizing this excellent meeting and for inviting me to be part of this. I think we had a very wonderful discussions right from her own presentation, where she gave us an outline about metabolic syndrome and the work that she's planning to do, and the whole group is going to be involved with that. It is indeed a very laudable project that she's taken up, and I congratulate her and SAFOMS for taking up this project. And then Dr. Ashraf Ghani spoke about the various aspects of metabolic syndrome, the challenges in diagnosis, how different organizations over the years have changed the definition of metabolic syndrome, but essentially it is a syndrome of increasing visceral fat, and that visceral fat is contributing to a variety of abnormalities that are manifesting in different ways. And not only that, I mean, it was over the presentations which we could see through all the presentations that it can manifest at different ages. It can start at a young age. We are seeing that also as a becoming epidemic, the epidemic of childhood obesity, and then over the years we see that it can present with in women as polycystic ovarian syndrome, and later on in life as early onset of cardiovascular disease, and metabolic syndrome at menopause increases the or multiplies the risk of cardiovascular disease in women who reach menopause with metabolic syndrome. So with this few words, I'll just put my presentation on. I know we are going behind schedule, so I will try to be brief, and basically with the excellent presentations that we had till now, even Dr. Gunaratne has highlighted so many aspects about the metabolic syndrome. He has spoken about how it is different in our part of the world, and he has actually highlighted all the factors that are contributing to metabolic syndrome in our population. So my job is made very simple after all these presentations. My job is only to connect some of the dots and show, probably bring out the link between visceral fat, how it contributes, how it works as the largest endocrine organ of the body. I mean, although we are speaking of various other endocrine organs, we speak of the thyroid gland, we speak of beta cells in the pancreas, we speak about diabetes, we speak of adrenals, but I think the largest endocrine gland is probably the visceral fat, and that has several different secretory functions, and dysfunction of this organ probably leads to several disorders, and metabolic syndrome being the most important one of them. And so I'll just give a brief outline about the functions of the adipose tissue, what are the different types of cells, and how visceral fat contributes as an important endocrine organ, and how its dysfunction can lead to various problems that we have already spoken about. So I'll be very brief. I'll probably take another 10 minutes or so. So if you look at the adipose tissue, it's a very specialized type of connective tissue that arises from differentiation of the mesenchymal stem cells into adipocytes during fetal development. The mesenchymal stem cells are pluripotent, and they can transform into various cell types, including fat cells, bone cells, cartilage cells, muscle cells, among others. This is important to understand, because what we see is that at different stages of life, there can be conversion of these mesenchymal stem cells, the pluripotent cells in different tissues, can get converted into fat, and that leads to a lot of fat deposition in different organs that we speak of. So if you look back and try to understand when this understanding about adipose tissue being a very active organ was known from a long time. 1948 onwards, adipose tissue was recognized as metabolically active. So it was not and deposition and mobilization of fat were shown to be important regulators of nervous function and endocrine functions. And then in 1994, leptin was discovered, and actually that made probably was a time when adipose tissue became recognized as an endocrine organ. From being just metabolically active to being an endocrine organ was when leptin was discovered. And as you can see, there are a myriad of receptors present on the adipocyte, receptors for insulin, receptors for growth hormone, leptin, angiotensin II. So a variety of receptors, even for some of the cytokine mediators, and also for estrogens, androgens. All these receptors are found on adipocytes, and therefore adipocytes respond to changes in the secretion of these various factors. And if you look at based on the origin of the adipocytes and the location, they can be divided into three different types. One is the white adipocytes, which are the most abundant type of adipocytes found in the human body. They are filled with large single drop lipid droplets and contain few cellular organelles. While the brown adipocytes are the ones which are very metabolically active cells that contain multiple lipid droplets and have a high concentration of mitochondria. So mitochondria, as we all know, is the organelle that is responsible that is responsible for generation of heat, and that's the reason why these adipocytes are called as the brown adipocytes. And then you have the beige adipocytes, which are in between the brown and the white adipocytes. They generally found scattered amongst the pockets of white adipocytes and have the potential to generate some amount of heat under conditions of such as cold exposure or during stimulation of specific nervous adrenergic receptors. So we have these three different types of adipocytes, and based on the type of adipocyte present in a particular adipose tissue, you could call it as a white adipose tissue, which is comprising of mostly of the white and beige adipocytes, and the brown adipose tissue, which is composed of only the brown adipocytes. And so the brown color is because of the iron content in the mitochondria of these adipocytes. Now, depending on the location, you could say that the adipose tissue can be classified as subcutaneous fat, visceral fat, bone marrow fat, and then you have visceral fat, which is predominantly found in organs of the abdominal cavity, such as the liver, intestine, and kidneys. As also it's seen in the peritoneum. It can be seen around the viscera, like the heart. Also, you have the visceral fat around the pancreas, which is also recognized to be very important. And this is all comprising of white adipose tissue. And in addition, we said that it could also be present in the marrow. White adipose tissue is also found around the pericardium surrounding the heart, and in all these places it provides a cushioning effect to the organs, and also in places like the soles of the feet it is present, the eyeball, and certain blood vessels. If you look at the body fat content, having looked at the distribution of fat, let us look at the total body fat content. And as we have heard from Dr. Gunaratne, that there is a significant difference between the body fat content of Asians as compared to Caucasians. We have the very famous YY paradox, where we have the photograph which shows the photograph of Professor Yachkin and Professor Yudkin.
So your photographs are not visible.
I have not put the photograph here.
Okay, fine.
I'm mentioning that this. We have this YY paradox, which is published in Lancet, where we have the photograph of Dr. Yajnik and Dr. Yudkin, and that speaks all, because with the same BMI, they have a very big difference in terms of their body fat percentage. 9% versus 22% was a difference. Similarly, what we are saying is that this body fat content can vary from 10 to 40%, and the place where the fat is distributed, whether it's more of subcutaneous fat or more of visceral fat, is very important. And we have various tools to measure this now. We have various bioimpedance machines. We have DEXA, which is probably the gold standard for measuring the total body fat, and that can tell us how the distribution of fat is present. And then we have specialized programs in MRI and other machines to look at the calculating the fat content in the abdomen at different levels. We can measure that. So what we see is that with increasing amount of adipose tissue, there are several health problems that are noted, including the development of the clustering of all these problems, which are the metabolic syndrome. And apart from the metabolic syndrome, there are a host of other problems that can happen with increasing visceral fat. So if we look at the major functions of adipose tissue, we know the classical function is to store the excess energy in the form of the fat molecules, which are mainly in the form of triglycerides. And this is regulated by hormones like insulin, glucagon, catecholamines, and cortisol, and which are regulating the lipolysis. Some of them are stimulating lipolysis, while insulin is promoting lipogenesis. And apart from this, they regulate, because of the production of various adipokines, they regulate the energy balance, they regulate the food intake and satiety. They also have roles to play in inflammatory responses and also in the metabolism of steroid hormones. And apart from the physical function of protecting the organs, this is how we see that the fat has the adipose tissue has several functions, physiologically has several functions. And apart from that, the brown fat, which we are speaking about, is very little in adults, but it's mostly a strong, a big component of that is present in children and in very early in life, and there it is playing important role of protecting against newborns against hypothermia, mainly by providing for the non-shivering thermogenesis, because they don't have the shivering mechanisms. In adults you have the shivering mechanism, so that helps in producing energy and thermogenesis, but in children, in neonates, this is the protection against hypothermia. So as we were discussing, adipose tissue produces several different enzymes, different hormones, and also paracrine and autocrine factors. So here you could see the illustration of various hormones which are coming out from the adipose tissue. I'll discuss a few of them, like leptin, resistin, and adiponectin. I'll just discuss a few of them. I'll not discuss all of them because we have a very short time. So these are the different hormones which are produced from the adipose tissue, particularly the visceral adipose tissue, while the subcutaneous adipose tissue also may produce some amount of this, but it is mainly the visceral adipose tissue, because of its very high production of these hormones. It has a great lipolytic activity and produces a lot of non-esterified fatty acids which interfere with the glucose and fat metabolism. So if you look at leptin, which I said was discovered in 1994, and that actually was the discovery of leptin gave the understanding that adipose tissue is an important endocrine organ. So it has influences on the development of cardiovascular disease by affecting the blood pressure, by affecting the aggregation of platelets, formation of arterial thrombosis, inflammatory vascular response. So all these are influenced by leptin. And what is important is that the leptin adiponectin ratio probably may be more important than just measuring leptin, because leptin, there is some amount of resistance to leptin, and leptin has significant influences on the timing of puberty, and many other endocrine events are regulated by leptin. And the leptin adiponectin ratio is emerging out to be an important factor which could decide, which could give us an understanding about the inflammatory role of the visceral fat. Now looking at adiponectin, as we have seen, adiponectin is different from leptin in the sense that adiponectin is a protective hormone, and it has a low levels of adiponectin are correlating with the development of cardiovascular disease, development of diabetes, high blood pressure. All these are strongly correlated with low leptin levels, and it is also correlating with endothelial dysfunction in patients with diabetes. And this leptin adiponectin ratio, as we mentioned, is inversely related to the intima media thickness of the vascular wall also, and has been suggested to be an indicator of atherosclerosis in patients with type 2 diabetes. Another interesting observation is that while we said that adiponectin is a protective hormone, or is a favorable hormone for cardiovascular disease or for metabolic syndrome, hyperadiponectinemia has been shown in some studies to be independent risk factor for diabetic cardiomyopathy, because it modulates the LV hypertrophy. So having too much of adiponectin also probably is not very good, but it is clearly shown to be a hormone which, when it is in lower levels, it is associated with more of vascular disease, as was shown in the in Dr. Gunaratne's slide. Also, he has shown in the study of South Asian study that there was a big difference in terms of the adiponectin levels in South Asians as compared to the UK population. It was almost half of the UK population level. Now, another important hormone that has been identified is resistin, which is again secreted from pre-adipocytes, more from pre-adipocytes than the mature adipocytes, and it again correlates with the development of ACS. One important thing is that what has been seen is that it's an important prognostic factor. If you're having somebody who has who presents with the acute coronary syndrome, who presents with a chest pain, and you're not very sure whether this person has got a significant cardiovascular coronary artery disease or not, you can decide it that the resistin levels can help in deciding that. So it's been seen that those with a greater degree of coronary artery atherosclerosis or coronary stenosis have higher resistin levels as compared to those who have got lesser degree of this type of disease. So resistin is a very good prognostic factor. Another hormone which has been recently well studied is apelin, which is again like adiponectin. It has got a cardioprotective effect, and it has because it has effects opposite to that of the RAS activation, that is the renin angiotensin aldosterone system, which we know has got unfavorable effects on the vasculature. So, and apelin is expressed in several organs, including the hypothalamus, vascular endothelium, heart, lungs, and kidneys, as well as the adipose tissue and the gastrointestinal tract also. And it has been shown to be substantially lower in patients with atrial fibrillation than in healthy subjects, and also those with heart failure tend to have lower apelin levels. Higher apelin levels are associated with better have cardioprotective effects. Another interesting hormone studied is the omentin gene. Omentin also has positive correlations with serum adiponectin and HDL cholesterol. So just like adiponectin and apelin, omentin is another hormone which is having favorable effects and correlates well with the HDL cholesterol. And this increases the insulin-induced glucose reuptake and participates in improvement of insulin sensitivity. So some of the favorable ones are omentin, apelin, and adiponectin, just like the HDL cholesterol amongst the lipid fractions. And lower levels of omentin are seen in patients with heart disease, and they correlate well with the number of cardiac events in the long term, and they have been shown to correlate with the need for repeated hospitalization or progression from NYHA class 2 to 4. You can see that omentin levels are correlating with that. Then RBP4 is another one which has been studied recently, and this is also correlating with the metabolic complications, and it's an independent predictor of CVD in females. So this may be an important factor which we see particularly in females. We find this retinol binding protein as a good predictor of metabolic syndrome and the consequences of metabolic syndrome. So what I was highlighting was a few of these factors, but what we understand is that these factors can be autocrine or paracrine factors which are working locally at the tissue level, at the abdominal tissue level, or within the adipose tissue itself, like PI1, the TGF beta. They all induce the production of IL-6 and other pro-inflammatory cytokines. And on the other side, you have the endocrine functions, or the hormones which are produced from adipose tissue, like leptin, adiponectin, and the other ones which we have just spoken about. All these have effects on different organs, not only on the fat itself, but on different other organs across the body. So as we said, the various factors which are produced from the adipose tissue, the visceral adipose tissue particularly, have influences on the vascular system. They have influence on the complement activation. They have influence on the extracellular matrix protein production, and they also have influence on inflammation and the development of various other pro-inflammatory factors. So as we said that whenever we are discussing about health and disease, the green part of it shows that normally in normal circumstances, when the adipose tissue is in the right context, in the right content, as you can see on the left side, that is the way the adipose tissue has to be in normal person. And here it is not producing any anti-inflammatory factor, pro-inflammatory factors, or it is not producing any harmful pro-inflammatory factors. But when it increases in size, as you can see on the right side, when there is excessive deposition of adipose tissue from excessive calorie intake and sedentary lifestyle and all the other factors which are contributing towards the metabolic syndrome today, what we have understood from the previous presentations, all of them lead to excess fat deposition in the adipocyte, and that leads to a dysfunction of the adipocytes, and which we call it as a adipopathy, we can call it, or a dysfunctional adiposity, we can call it. And that leads to the production of pro-inflammatory factors, pro-oxidative factors, pro-thrombotic factors, pro-atherogenic factors, and ultimately leads to endothelial dysfunction, development of cardiovascular disease. So that is how obesity is contributing towards the development of all these problems that we have just spoken about at length. We have spoken about metabolic syndrome, the various components of metabolic syndrome. All these are produced by a dysfunction of the adipose tissue, which we are speaking about. And this is highlighting the same thing, that when the adipose tissue is in the right context, in the lean person, you're seeing that, so you can see the green box showing the normal metabolism going on, normal vascular functions, and the immune functions being regulated in the physiological manner. While with the obese individual with increase in visceral fat deposition, you see the development of all these problems in the form of hypoxia, adipocyte necrosis, all activation of immune cells, activation of the pro-inflammatory factors like interferon alpha, interferon gamma, TNF alpha, MCP1, IL6, IL beta, or IL1 beta. All these are produced, and they are producing the various factors that we speak now. So what we are saying is that this term adiposopathy indicates a disease of adipose tissue starting from damage to one or more of its components and causing a dysfunction in the metabolism, the metabolic and endocrine functions of the adipose tissue, the growth capacity of the adipose tissue, the plasticity of the adipose tissue, and therefore it plays an important role in the development of obesity as a disease, a complex disease associated with several metabolic alterations involving different organs, tissues, and cell types. And there is what you can say is, to summarize this, what we would say is that you have the TH1 type of response, which is a pro-inflammatory response, which is stimulated by excess fat deposition, while the TH2 response, which is a anti-inflammatory response, is the expression of those anti-inflammatory factors happens in normal physiological functions. I mean, in a person who is non-obese and has the right amount of fat, visceral fat, then he has more of the expression of the anti-inflammatory cytokines from the adipose tissue, while when the person gains weight and has more of visceral fat, then there is a pro-inflammatory component activated. And there is, when fat increases, there is initially hypertrophy, hyperplasia, or increased proliferation of this, and replacement of this fat happening in different tissues. As you can see with age also, there is a remodeling of the adipose tissue, as you can see here, and that is why it becomes from a physiological adipose tissue with proper successful aging. This is what happens, and there's a balance maintained between the pro-inflammatory and anti-inflammatory factors. With pathological aging, there is increase in the pro-inflammatory factors, and this is what we are discussing when we are saying that with aging, when we are going towards menopause, if there is increased weight gain, there is increased production of these factors, and there is the development of metabolic syndrome. So in essence, we are saying that age is one factor. With aging, what happens with excess deposition of adipose tissue in the intermuscular compartment, in the bone marrow, in the pericardium, in the mammary glands, in the mesentery, and in the thymic areas. These are all the places where excess fat gets deposited when there is excess calorie intake and a positive balance in terms of the fat, of the calorie intake. And the epicardial fat also has an important role to play in the development of cardiovascular disease. As we said, the epicardial fat, when present in the appropriate amounts, is protective, but when it's present in higher content, it has a very strong factor in terms of contributing towards the development of cardiovascular disease. Similarly, perirenal fat has been shown to contribute to be correlated with the development of CKD and progression of CKD. And as you can see in this picture, we are seeing that it's not just the fat in the abdominal compartment, but the perirenal fat, the epicardial fat, the fat in the muscle, the fat in the bone marrow, all of them, and the fat in the liver, as we are seeing, have significant effects on the metabolic functions, and they contribute towards the development of metabolic syndrome. Now, to add to this, probably to this picture, is that even the peripancreatic fat has been found to have an important role to play in altering the beta cell function and the development of diabetes. And these adipose tissue also has an effect on the development of various cancers, and you could see the initiation of cancer through the activation of some of these inflammatory factors. Another important factor that has to be understood is that there is with dysfunctional adipose tissue, there is increased expression of certain of these genes, adipokines, and while there is suppression of the while there is underexpression of some of the protective adipokines like adiponectin, omentin, and all these are expressed to lesser extent in people who have the metabolic syndrome, and while those who develop the metabolic syndrome have overexpression of the other pro-inflammatory the genes of the pro-inflammatory cytokines, or even the mRNA expression, explaining the genetic basis of most of these problems. So I would like to conclude by saying that a continuous overflow of energy substrate, which is overwhelming the storage capacity and the expandability of the adipose tissue, leads to the deposition of excessive visceral adiposity in the liver, muscle, heart, and contributes towards the development of a pro-inflammatory state with the development of various components of the metabolic syndrome. And ectopic adipose tissue accumulation represents a predictor for organ dysfunction. Preventing the appearance of this dysfunctional adipose tissue is certainly the prerequisite to avoiding the progression towards most of these problems which develop because of obesity, and certainly the metabolic syndrome about which we are discussing today. Thank you all for the patient hearing. I would like
Thank you, Dr. Rakesh Kumar. It was a very lucid presentation from an endocrinologist. And I thank Maninderji for keeping me in this session where there's a sandwiching of gynecologists with endocrinologists, and we are really learning a lot and giving me a chance to be with my counterparts in Pakistan and Sri Lanka and Bangladesh, and all the presidents are here. So it's nice to meet you virtually, even though we are not meeting initially. It was a very lucid presentation, and it was interesting that you are saying this fat is like ligaments, connective tissue. My God, it's the first time I'm hearing someone talk of fat as connective tissue. I thought all those ligaments are the only ones. And if you grow more fat in your tummy, you can't walk because you have inflammatory markers in your knees. So that is very funny, you know. But the good part is that you don't need the AC. You can sit in any AC because you feel very cool, warm because of the thermogenic effect of the adipose tissue. But if it is too much, it's too bad. So it was a very lucid presentation, and I feel very ashamed now that we are just in the stage of finding out how many people have metabolic syndrome in India, where other people are sitting and finding out the levels of leptin and adiponectin and whatnot and things like that. So like in a large country like us, we need to have more money to be, you know, doing all these things. We are stimulated by your talk that we should have more Maninders doing research. And I hope we have more money to sit and find out how many leptin levels we have and, you know, things like that. That's also there, because our people can't sit and do leptin levels and adiponectin levels. Our patients won't pay, and we are not insurance paid. I don't know about Sri Lanka, how it is. Sir, Professor, how is it? My country has a lot of money to do leptin and adiponectin studies.
Sri Lanka.
I say,
the present time.
Not like that. Earlier, they used to have a lot of money. I visited with Sri Lanka, although the Indian money was little more than Sri Lankan money. Things were a little affordable there.
Shobna, I think I'm very grateful to you that you have been sitting so patiently, especially you had some duties also. But the fact which you have highlighted that we have to start the research somewhere. That is my funda is there. Thinking that we cannot do a higher level and we don't start at a lower level is the inhibition which we have to overcome. So I could do it at this level because I've been trying to do.
Great. I'm appreciating.
Yeah. But I'm very 100% sure that now the ICMR will pitch in. Now the fund companies will pitch in. And now we'll have sponsors to help us in this research. Because we have shown them, we are going to show them that yes, sitting in India also, we can do a good international study also. So that is why my purpose to move that one step, which I am taking, we should be taking that.
Yeah, you are bringing in people who are telling us what is going on in the world.
See, this is a multidisciplinary team. Now, health of the woman is a multidisciplinary teamwork.
Yes,
it's not one specialty working. So holistic healthcare, with that aim, I had founded that Society of Meaningful Life Management. The purpose was not to divide women's health into a adolescent, prenatal, this thing, everything is connected now. And the today's talk has beautifully highlighted how we are connected from prenatal, from rather in utero origin to the neonates also, then adolescent, and then pregnant and menopause. So we have connected everything.
Today I learned that the neonates don't shiver. First time I'm listening to this.
Yeah.
कभी सोचा नहीं था. I don't know.
पंजाबी में एक होता है साढ़े नाल रोगे तो ऐसे करोगे, तो हमारे साथ रहोगे शोभना, तो we learn many more new things coming up. So साढ़े नाल रोगे तो ऐसे करोगे. I think now, because we are running short of time, we should go into that very important discussions, how at the country level now we are going to take it up. So I am starting from the last slide now. Well begun is half done. So we have well begun now, and I think our half work is done. And now I'll be coming to the countries, especially first India, whom we have recruited so far. Yeah, tentative centers involved in India is PGI Chandigarh, Dr. Neelam, she's not here, Dr. Jaideep Malhotra, Rainbow Hospital, Jammu, Dr. Sudha Sharma, ESI, Faridabad, Dr. Priyanka Sharma, AIMS, All India Institute of Medical Sciences, Dr. JB Sharma, Dr. Richa Sharma from UCMMC and GTB Hospital, Dr. Poonam from Maulana Azad Medical College, Dr. Priyanka Roy from East, Dr. Ruchika from Agra, sorry. And there are many more who will be coming, Dr. Adita Kant from Faridabad and Dr. Jyoti Jaiswal from GMC Raipur. So what we have given them is tentative to collect data of 200 at least cases, which they start 1 or 2 cases per day or 3 cases per day, so they can easily do that. And I think in 3 months, we'll be able to collect the data. Dr. Priyanka, do you have to add anything? Because I just can see now Priyanka only here. How you are collecting your data?
So, ma'am, we are basically collecting it from our patients. And since we are a government-funded institute, even getting the sampling done in the tests is not a problem. It's a very nice, simple questionnaire, and it's very easy to administer to our patients. We started on the 1st of May, and I think I've been able to cover around 40 patients. Good. So I think we are going in with full steam ahead. Good, so very good. I got institutional clearance in the end of April. So then I've been working on it.
Thank you. So that's very encouraging for India, and other centers have also got either ethics clearance or they didn't need the ethics clearance and they have started the data collection. Now we come to the Bangladesh, Dr. Sheikh Jinnat Nasreen, are you here? Dr. Jinnat?
She's here.
Yeah. Will you please talk about your?
Can you hear me?
Yeah. Should I remove the slideshow? Stop sharing, because we can just pick the countries now, okay?
Right.
Stop here, then we can look at each other, yeah.
Yeah. Thank you very much.
Yes.
Dr. Maninder, I have already very good discussion with the Brigadier ma'am, and we are very much happy to go with this research project. Thank you for this wonderful initiative. Now, I have talked to several doctors. 3 of them are very keen. So I talked with them, how they will proceed, I will tell them later. Dr. Shahi Farzana, Dr. Nusrat Mahajan, and Dr. Sumaya Bari. So they are happily agreed to go with the project. So the problem is that our women can't actually download the Google form or write down or fill up there. So what I'm planning, we'll do the hard copy. We'll download, and then they will get share with them, and they'll feel when they'll come to the clinics. Just one thing I'll finish one thing by saying that 3 months is quite less for us, because we have to go for the ethical permission, and then we have to collect the data. And you have given us 600 data, 300 for postmenopausal, 300 for premenopausal. So you can be for 5 months like that, it will be okay.
We will extend the date. We can extend the date. We can apply for that. It's no problem. So different countries have different problems. At least we'll be able to do it. The only thing which I can advise you, use your personal influence on these ethics committees just to hurry up. Not the otherwise, but just to use. And if you need any clearance about international laws, I can give you always a helping hand in that. So I don't think that's going to be any problem, because we are doing very simple data collection. There is no exchange of biomedical appeals. There is no question of finances even. So it will be easier getting it done.
Thank you. From my
And you just have to collect 600 only. We have to collect 20.
You're
23, but then we are a big country. Yes, we are a big country. And now Dr. Rubina.
Yeah, so the situation with us is that we have to get the bioethical approval from our bioethics committee and individual approval from the hospitals as well. So we are in the process and we have already applied, but today I found out that for bioethical approval in the center, we have to pay a fee of 50,000 rupees. So we are planning to contact some pharmaceutical and see how can we go about it and if we can find some support to get that bioethical approval. Otherwise, I was thinking that we could go for bioethical approval from individual institutions, which will be a bit tedious process, but it can also be done. Now, regarding the various people who are involved, I have at this time a list of about 8 people who are willing to participate and facilitate the study. Their names are Alia Bashir from AIMC, Rubina Farooq from SIMS, Shaida Tara, GMC, Shamaila Ijaz, FGMU, Asfar, LMC, Mariam IMC, Saima Zubair, and Shaila Bakai from CMH. So these are our names, but a little sorry to say that we haven't started as yet, but we were trying to put things in place and hopefully we'll be starting pretty soon. So some of the things have been organized and they are in order, but this issue of approval is still pending, so we are waiting for that approval.
Rubina, you're forgetting our institution in Islamabad.
Oh, I'm sorry. Oh, I'm sorry. Yeah.
Saida is a very active member, yeah. And Sumbul will also be very active, I think.
Yes, Sumbul will be there, Rubina Hussain and Batul. I'm sorry.
There will be another, I think, name I'll give you. She wanted to, she always contacted me because she wanted to work. Tomorrow I'll find her name and give it to you. Okay. I told her that whenever there is some
we are actually Menopause Society meeting, Pakistan Menopause Society meeting in a week's time. So we will get our local people in Pindi, Islamabad to get interested in this study, because we've now just increased our recruitment and more membership of our Pakistan sort of reactivated. So we've got lots of members into the Pakistan Menopause Society, and we are hoping that in this meeting we'll share this study, and I'm sure we'll more people interested, but obviously the ethics and things would take a little longer. So perhaps 3 months may be a little short, subject to ethics. It is, you said, it is usually we can sort of make people listen to us so probably within a week we should have our approval for the ethics committee. But it is a process. It is a process. So we will be able to get.
Okay. So I think I'm glad that Pakistan is also moving ahead. So is Bangladesh. And now we come to Dr. Dicky from Nepal. She has already shown they have started public awareness also. And
thank you.
Your ethics approval.
Yeah, thank you. We also had a recent meeting regarding this study, and everyone was quite positive about the study. And we have selected few of members like Dr. Snigdha, Dr. Niva, me, and we are still waiting for other people to join in as coordinators. These two are from one of the major hospitals of Nepal. And but we haven't been able to get from other smaller cities. So we are just focusing now only in Kathmandu. So hope we can get more coordinators and who could help us in getting the information. I think the problem here will be the ethical part, because it is a multi-center, a multi-country, I would say. So we need ethical, not only from the individual hospitals, but what we discussed was we would need the ethical clearance from the national center. And that is I think is going to be quite a long process and may not be, in 3 months, maybe a short time. So we may be needing more time. So we are trying to make the proposal in line with the ethical committee of the NHRC. And so we are going forward with that. And so hope that we can, they'll approve of it. So that is one step that we will be taking. And what we thought was, instead of getting approval from each and every hospital, that would be very difficult, so we thought that we could, go with the organizations like the NESOG or MESON and say nursing also, and then maybe we could use them. And then, so then we wouldn't have to take, ethical approval from each and every hospital.
Yes.
Then it will just be an organization, individual. So if the NHRC will be willing to, give ethical approval based on that, then that would be good, I guess.
I think, Dr. Dickey, that is what is required. You don't need any national approval for this. You take a few hospitals, just take their approval only, and that's all. And their approval will do good for the private practitioners also. So you
No, I think in what we discussed with the seniors, they said that we need an approval from the NHRC as a central one. Individual hospitals, I don't think it'll be enough.
If you don't have, then there is no problem in approval, because as long as the finances are not involved, as long as the
I think if the NHRC has a look at the proposal and then they're okay with it, then I think we can go forward. If they don't object to it, yeah.
But I again advise you a little use your advocacy, so that you tell them why this project is very important for all the South Asian countries and for the health of women, because each country is now concentrating on the health of women. So they are making WHO also the health of women, the centered. All the projects, they have to be centered around women, and women's health is utmost important. Especially midlife women have been neglected, and once we impress upon them, I think the things will become easier then.
Yeah, so we are planning to talk
must
with the
have some personal strings to
yeah, because I think in the central, the NHRC, the list of cases that are going for review are very long, so it takes a very long time. So we'll have to talk with them and try to get this, if we can see if we can try to get it done earlier or faster. Yeah.
Yes. Doctor, from Sri Lanka, we have Dr. Sanath. Doctor, sir, hello, doctors. Now who will be talking? Piyusha, or you will be talking how you are going to do? Because I know the conditions are not that good.
Yeah, that is what I want to tell you. I know this study is very important.
Yeah, I talked to her personally, and she said they are making their efforts, but the financial condition at your level.
Financial constraints are there. Other thing is the ethical issue. We need to get the, as other countries mentioned, there are difficulties in getting the ethical clearance also. We need some information. I think Piyusha have written to you, Manindra, about that. So
I have given you all the information. I'll send you my ethics clearance also.
Please.
I'll send you send you even the international laws also about the ICMR. I have read everywhere. And they, as long as it is being done under technical collaboration of the professional bodies, and no finances are being involved, everything is clear, because we should not be harming anybody. We should not be doing any wrong thing. Here we are just doing a public awareness program. This is for the health of the women. This is sort of an awareness that every woman above the age of 35 years at least should have her lipid profile and blood sugar done. This is the minimum, like getting your hemoglobin done. So I don't think there should be any problem in getting approval for this thing.
Yeah, we'll try our best.
Priyanka had some problems, so we sort of had an understanding and talked to them. I have read the laws, and I sent them the reference also. I can send those references to you also. Then it's no problem, because ethics, why the ethics committees were made? Because of the war crimes, because of what was being in the name of research. So if we are not doing anything, no biomedical material is there, no finances are involved, so no gapla, wrong things are being done, then there should not be any hindrance in getting the ethics approval.
Yes, we'll do our best.
Yeah, please.
Okay, thank you. Please send us all documents. Yes.
Yes.
Thank you.
Any points? I'm sorry, this is the first time we have been delayed, but the discussions were so good and the speakers were so good. I didn't have the heart to stop. So anyway, I'm very happy with the results, what we have come out, and the future is bright. And I think all of you agree on this.
Maninder, I just have a small question. Can you tell us the exact number of participants that we need from Pakistan?
From Pakistan, you need the same as from India. That is pre-menopausal 1200, post-menopausal allowed 1100, roughly.
Okay, thank you.
So that way you'll have to keep the centers, keep about 20 lady doctors. Tell them to keep at least 100. 100 is easy. I've seen, because this age group is so wide now, 35 to 60 years. So any patients walking into, any attendants walking into, you can, any friends walking into, your staff. So lots of data is there. That's why I started with healthcare workers only, because we have those number of healthcare workers also. So the only thing is initiating and advising and counseling them that yes, for their own health purpose, they should get it done.
Yeah, with us, there's a little bit of issue of cost as well, because all the hospitals are not getting those investigations done free of cost. So I mean, some hospitals it's costing around 2,000, in other hospitals it's costing 400. That is why we need more number of facilities, so that people who can afford it, we will encourage them to spend the money themselves. And people who can't afford it, we will get some pharmaceutical support.
And we also need data from affluent classes and from the low income group. We also be getting that data. So that's good, because we'll be getting from different sections also.
Different sections of the
society.
Yeah, thank you.
I didn't make this divide into rural and urban purposefully, because that would have confused the matter a lot. Dividing how to do which area is urban, which is urban, and now because the so much like urbanization is occurring even in the rural areas. So if you look into the physical factors of activity, they are more resting, doing less of physical activity than the urban people also now. So that's why I did not keep that divide, because over the years the things are changing now. So whatever the important factors we are looking into, and then subsequent studies will come up. That is what we can do. Inshallah.
Yeah, inshallah. Yeah. Yeah, but I agree with you, because urban and rural might have complicated it a little bit. So it's okay to keep it simple.
So I didn't want any complication where the data can be easily, and because if you have too many of confounding factors now, then you don't come to any conclusion also. So we can't have too many confounding factors also.
Yeah.
So whatever is feasible, practical should be done, because that is taking one step forward. बाद में देखा जाएगा. God, Allah, Christ, everything, Vaheguru, they are going to help us, because we are moving ahead with good intentions. So we are moving with good intentions.
Yes, you will do well, Maninder.
Thank you very much for infusing all this energy in all of us.
And thank you, Jagsonpal. I think
rural India is fast disappearing like everywhere, I think.
Yes,
There are no forests left anywhere in the world. Now there are no rural areas also left in the world.
Yeah, I 100% agree.
Everybody is now urbanized.
So I think we have covered with everybody now. And thank you, everybody. Thank you, all the countries,
Okay, good night. Nice meeting all of you from Bangladesh.
Deepika, thank you very much. Thank you to the Jagsonpal for being with us. And I'll see how I can utilize you in this project now.
Thank you.
Thank you, everyone.
Yeah, Rubina, you can utilize these pharma companies also in your campaign.
I have actually made a list of,
rather than giving us any gifts to doctors, you give them health gifts and get them tested. Give them 10 tests, 100 tests free of cost.
That's a lovely idea. Thank you very much for this. Thank you.
Thank you.
Okay,
Good night. Good night.
Bye-bye.